Neuro-Oncology. I, Namra Aziz, am your host for this session. We are honored to have Dr. Tariq Khan as the session chair with us today. Dr. Khan is the Dean of the Northwest School of Medicine in Peshawar, Pakistan, and a professor and head of the Department of Neurosurgery at Northwest General Hospital and Research Center. We have an esteemed group of speakers for today's discussion, and before we start, if any of you have any questions for our speakers, you may ask on onlinequestions.org by entering the event pin 13419. Our first presenter for today is Dr. Hughes Defoe. Dr. Hughes is a leading surgical neuro-oncologist. He is a professor and chairman of the neurosurgery department in Montpellier University Medical Center, France, and is head of the INSERM 1191 team, Plasticity of the Central Nervous System, Human Stem Cells, and Glial Tumors at the Institute of Functional Genomics, University of Montpellier. Today, he'll be speaking on early maximal safe resection for low-grade glioma, a connection-based surgical approach over 1,100 awake procedures. Over to you, Doctor.
Thank you very much for your invitation. Very happy to participate in this first neuro-oncological meeting. And I hope that you will enjoy some data we collected these past 20 years, speaking about low-grade glioma and awake surgery in France. Now we can say that with 20 years of follow-up, we increased both overall survival and quality of life of these patients. I'm very happy to show you original results based on this concept. First, early surgery. We have not to continue to use the wait and see to apply the wait and see attitude. Second, maximal resection. We have not to stop according to what we can see on MRI, but to apply the concept of connectomal-based resection. And third, then to preserve the quality of life or even to improve the quality of life with more than 10, 15, 20 years of follow-up. I will not insist on the fact that these tumors are not benign, that they are becoming malignant in all cases, and finally in the classical literature applying the wait and see concept, the median survival was around 6 to 7 years. We have also to be objective regarding the quality of life of patients. It's commonly claimed that these patients are well before any treatment. This is not true. Please do an extensive neuropsychological examination and you will see that in more than 80% cases, they have deficit regarding working memory, attentional processing, executive functions, but also emotional processing, personality. And this is very important to integrate in the strategy. Indeed, we have understood now that these deficits were not related to the location of the tumor, but to the invasion of the connectivity, which is the limitation of neuroplasticity. For instance, if a patient has already an invasion of the inferior frontooccipital fascicle before surgery, then in the vast majority of cases, he will have semantic disorders. But you need an objective, extensive neuropsychological examination to know that, and of course, to adapt the surgical strategy accordingly. We understood, thanks initially to Mitch Berger, that the volume of the tumor was correlated to the risk of death, the malignant transformation. We reproduced these results in France, about more than 1,500 cases, and we introduced the concept that beyond the volume of the tumor at diagnosis, it was very important also to understand the kinetics, the growth rate of the tumor. In other words, you have to do 2 MRIs. Then you can calculate objectively the volume and then to extract the growth rate. And it's not a surprise because if the tumor is growing faster, that means that the prognosis is worse. And this is finally much more efficient predictive at the individual level rather than the WHO classification. And this is the reason why we demonstrated also that this growth rate was not related at the individual level to the molecular pattern, which is just a part of the history. For instance, in this paper, we demonstrated that you can have a tumor growing very slowly while they are wild type. And recently, we confirmed in the Journal of Neurosurgery our series with wild type astrocytoma, which were operated on with extensive resection. And of course, we confirmed that sometimes they can have a glioblastoma-like evolution, but in 15% cases. In more than 80% cases, you can follow them without chemoradiotherapy, and they will have a natural history typical for a diffuse low-grade glioma. That means that by applying the concept of molecular biology is the Bible, more than 80% patients will benefit from Stroop protocol for nothing if you did an extensive resection before to decide what we will have to do following this resection. Typically, you know, I'm sure these papers, not from Montpellier, because they were a kind of reference. If you do just biopsy, then the median survival is only around 6 to 7 years. It's not my imagination. It was not 20 years ago. But in our series, and first of all, the series by the Glioma Consortium in France, the median survival is more than 15 years, about more 1,000 cases. So we changed radically the natural history of the disease. And this is true because we did very regularly reoperation. The goal is to decrease the volume of the tumor to avoid malignant transformation, or at least to delay it. So that means that now I started to do a fourth resection 20 years after our first one without chemoradiotherapy in the meantime. And of course, in patients enjoying normal life, what we will see now, because in fact, we have to adapt the strategy according to the knowledge of the functional anatomy at the individual level. So that means that I have no reason anymore to do biopsy in this kind of tumor, and I did not perform any biopsy for more than 10 years. But on the other hand, I do systematically a functional mapping in order to understand the connectome of this patient at that time. And you will see that in the same patient, you can see modification of this connectomal organization over years or over decades now. Indeed, classically, we have the habit to say that these tumors are located within eloquent areas, SMA, insula, Broca's area, Wernicke's area, and so on. I don't know what means eloquent area anymore, because we have understood that the localizationism does not exist. I will show some slides at the end of this talk, and you will see that we published recently a new model of the brain in Physiological Reviews, which is the Bible of physiology for humans beyond surgery of the brain or glioma surgery. So that means that we have understood that different networks are underlying different subfunctions, and now we have to understand the dynamics between networks. So that means that plasticity exists, and we have to better understand that at the individual level, not only before, but also after surgery, in order to improve the quality of life, but also to prepare a second or even a third surgery in order to reduce again and again the volume and to avoid malignant transformation. I am PhD in functional neuroimaging. I can tell you that it does not work at the individual level. And this is the reason why I do not use functional imaging into the operating theater for more than 20 years. Why we published recently papers comparing, for instance, intraoperative mapping and fMRI. You can see the sensitivity and specificity. How do you want to make any decision regarding the surgical planning and surgical selection based on this very poor reliability? This is true for DTI also. We did intraoperative subcortical electrical mapping compared to pre and post-operative DTI, and what happened? More or less the reliability just around 80%, which is absolutely amazing regarding didactic tool, research tool, but not as a clinical tool. If you do not believe me, please ask to the specialists in the world today, engineers, giving you this kind of beautiful track, but which are not valid. As you can see, tractograms contain many more invalid than valid bundles. About 20 research groups in this field published in Nature Communication 3 years ago. So we have to see the truth in front of us. And for 24 years now, I have the habit to wake the patient, whatever the location in the brain, because I understood that most important is to do a cognitive monitoring online and to do a cortical and subcortical mapping, because once again, white matter tracts are the limitation of neuroplasticity. So we have to adapt the tasks online and to do real-time anatomofunctional correlation. And of course, I will not insist about these tasks, but just to say that we have to adapt them to the quality of life of the patient defined by himself or herself. I mean, of course, they don't want to be hemiplegic and aphasic. I touch wood. I did not induce any aphasic hemiplegia since 15 years. But is it enough in order to enjoy normal life? We need to adapt to the job, the hobby, habits, leisures, lifestyle, and so on. But we have to adapt according to the environment, which is not the same, I'm sure, in Pakistan in comparison with Europe or US. Regarding the legal issues, the cultural aspect, socio-economical parameters, and everything should be taken into account in order to provide the best for each patient, and finally, to have a set of tasks you will apply into the operating theater in real time for 1 to 2 hours, not only to map the cortex, but most of all, the association and projection fibers in the depth in order to stop the resection according to the connectome, the functional boundaries. So in the operating theater, I have the habit to forget the tumor. In other words, I do not use fMRI DTI. At the individual level, it does not work. I do not use neural navigation. You have a shift. I do not use intraoperative MRI. The flare is not the disease. If you can remove more, please do that according to the functional boundaries. I do not use microscope. I have good glasses and I can see the 3D reality functionally and anatomic structurally speaking into the operating theater throughout the resection. I do not use ECOG except for research purposes sometimes. I do not use robot. So in other words, you can do that everywhere in the world with just a fork and a knife, and you will see the results, of course. But yesterday, I did a wake surgery in the right non-dominant hemisphere because I identified empathy, I identified semantics, non-verbal semantics, and so on. Why to continue to say in the left hemisphere, we have understood we will awake patient in order to preserve language, and in the right hemisphere, if the patient is not hemiplegic, we're happy. No, the right hemisphere is critical for so many functions in order to enjoy the real quality of life. Movement is not just to avoid hemiplegia, it's to be a pianist, for instance. You have to adapt to the style of the patient. Spatial cognition, otherwise you cannot drive. Social cognition, otherwise you cannot enjoy normal life into your professional life. Non-verbal semantics, we are not speaking all day long. Working memory, to continue to think about many things simultaneously in order to make a decision online. Personality, behavior. Is it possible to map and to monitor that into the OR? Of course, we are doing that for more than 10 years, speaking about this higher cognitive and emotional function in order to give really for the patient the possibility to enjoy a perfect normal life, and not just to say, oh, you can see I took a picture after surgery, the patient is not hemiplegic, so I'm happy. The question is to know if the patient is happy 10 years, 15 years, 20 years later. And to do that, once again, we have to accept, I'm sorry about that, but that look should be burned. And finally, neurologists were obliged to accept this kind of papers based on the truth we observed before, during, and after surgery for more than 20 years. So that means that we have to adapt the different tasks according to our knowledge of the neural foundations underlying judgment, calculation, spatial cognition, what the patient wants according to his lifestyle, in addition to movement and language. And of course, because we are human beings, first of all, emotion. We are emotion, even if we don't want to recognize that. In meetings, you know that after beautiful discussion, most of the time, big masters are telling, I believe that. We are emotion. If it's true for them, for the neurosurgeons, it's true for the patient. So it's very easy, once we have understood that, to do the cortical mapping, but also the white matter tract identification regarding, for instance, of course, the movement. Here it's just we have to avoid to induce any damage at the level of the internal limb of the posterior limb of the internal capsule to avoid hemiplegia. Okay, but it's not enough. If you want to be a surgeon following surgery, because I operated on many surgeons in my life, and suddenly they did not tell me, you think that I will be hemiplegic? They told me, you think that it will be possible for me to enjoy a normal life by doing surgery again? You need to have a beautiful, perfect bimanual coordination. And we published last year the atlas, cortically and subcortically speaking, regarding the neural bases underlying the control of accurate movement. So beyond the fact that we are not hemiplegic. It's true for the awareness of body schema if you do this kind of surgery in the parietal lobe, because you need the somatosensory feedback, but also the awareness of your own body. If you have not that, you will not have a beautiful movement, and you will not be hemiplegic. So you can take the picture of your patient after surgery by telling, you see, it's perfect. No, this is not the truth. Same thing regarding the visual pathway. You can have a patient in front of you telling, I feel well, but in fact with a myopia. That means that, I don't know in Pakistan, but in France, you cannot drive anymore. So the life is not the same. Spatial awareness, we spoke about the cortex, white matter tract. We have to preserve the connectivity, and especially the part 2 of the superior longitudinal fascicle. You can publish in Science, you can preserve the quality of life of this dancer, and you can better understand your neural bases underlying spatial awareness. Everything is linked. For language, you know that we have a dorsal pathway involved in articulatory processing and phonological processing, so the SLF and the arcuate fascicle, and we have to identify them at the end of surgery, whatever the location, parietal lobe, temporal lobe, frontal lobe, because I have the regret to tell you that the arcuate fascicle does not connect Broca's area directly to Wernicke's area. And now we have understood that in the field of neuroscience. And we have understood also that there is a very important semantic pathway, the inferior frontooccipital fascicle. You have to preserve it when you do this kind of surgery. Otherwise, the cognitive assessment of the patient 3 months following surgery will not be normal. And this is a very good landmark when you do insular surgery in order to stop the recession according to the IFOF running within the temporal stem, which is the lateral part of the anterior perforating substance. Because I understood that the rate of permanent deficit related to deep stroke in insular surgery, I did approximately 300 low-grade glioma, is now 0. We have to understand that if you cut the anterior part of the more basal inferior longitudinal fascicle, the patient will be able to speak, but with an increase of reaction time regarding the lexical access. Is it good or not? You have not to decide for him. You have just to explain before surgery, can you live with that? And if yes, I will remove a little bit more. So it's very exciting, because if the patient can accept to have an increase regarding reaction time regarding the lexical access, then you can cut the anterior part of the ILF. You can remove the temporal pole, which will be compensated by the contralateral hemisphere, and you can cut the incinate fascicle, even if you have some disorders regarding the lexical access to proper name, you have to ask to the patient before. But everything except that will be compensated by the IFOF with different layers I cannot detail today. So this is the mechanisms of neuroplasticity based on the fact that it's not one area able to compensate another area, but one network able to compensate another network. Be careful nonetheless, because if you cut the IFOF in the so-called right non-dominant hemisphere, the patient will have some deficit regarding non-verbal semantics. You understand what I mean? But also emotional processing. I mean the ability to recognize the emotion of people in front of you. And it's possible to use this task into the operating theater. I did that yesterday, and I stopped according to this limitation in the so-called right non-dominant frontal lobe. I did a supratotalization, and the patient is perfect, but perfect regarding also the cognitive tasks. Otherwise, if you cut the IFOF, once again, in the right non-dominant hemisphere, the patient can have some kind of modification of the personality due to empathy disorders. Maybe he will tell you, I don't care, what I want is to live longer, okay? But you have to give this information before surgery in order to give the choice to the patient. But stop to say we have to operate into the right non-dominant hemisphere under general anesthesia using MEPs and that's it. You see the model we did recently, and very simplistic, of course, of all functions we spoke about very quickly today, summarizing the role of the right so-called non-dominant hemisphere. It's beyond to avoid left hemiplegia. So results about more than 800 diffuse low-grade glioma, more than 1,100 awake surgeries, because I'm doing more and more reoperation, as I told you, because patients still alive and because I become older. So within so-called eloquent areas, I don't know what means, Broca's area, Wernicke's area, behind the labia vein, central area, corpus callosum, blah, blah. Okay. Mortality 0. 0.5% of severe permanent deficit related to deep stroke when I was younger, because I did not yet understand what I told you regarding the anterior perforating substance and the temporal stem, which was a little bit lateral. Now I understood. So 0 deficit for 15 years. 30% of improvement thanks to post-operative cognitive rehabilitation, which is call for neurosurgeons to understand. Do post-operative rehabilitation, you can do a very extensive resection and the patient will improve in comparison to the pre-operative cognitive status. 80% of positive impact on epilepsy as in the classical literature. If we can do that in Montpellier or in San Francisco or in Shanghai, you can do that everywhere in the world. It's exactly the message of this meta-analysis we did with Mitch 7 years ago. So now the goal is to try to reoperate and to better understand mechanisms of neuroplasticity at the individual level, not only before, but after surgery. For instance, reorganization in the contralateral hemisphere after SMA syndrome, and of course, recovery. So it's very exciting to see that many years later, you can do another fMRI, and of course, it's not the absolute truth, but you can compare to the first one in the same patient and to see the modification of the map, and to use this information in order to reoperate the patient, to do wake surgery many years later, and to remove more, in this case, the so-called knob of the hand, while the patient is a guitarist. And now we are doing the same thing, not only for movement, but also for language. And we published very recently pre and post-operative fMRI using resting state fMRI in patients who recovered following resection in the so-called left dominant hemisphere. So that means that, of course, resting state fMRI is beautiful for research. For instance, in this case, I was not able to remove completely the left temporal lobe during the first surgery because so many hub still eloquent during the first surgery, but 10 years later, I removed the so-called Wernicke's area by preserving, of course, the arcuate, the IFOF, and so on. Or the Broca's area, I hate to lose. I was not able to remove Broca's area, the pars opercularis in this patient during the first surgery. I did that 10 years later. And once again, no chemotherapy, no radiotherapy, which is against the plasticity mechanisms. So we have to reoperate after a first period of postoperative cognitive rehabilitation to induce plasticity. Or sometimes very provocative resection, but once again, this patient has been, published in Brain and Cognition, so that means that you cannot publish in this kind of papers, journals, without 5 hours of extensive cognitive. So that means that this patient can have a very good cognitive and also metacognitive scores. So once again, it's not against the quality of life because and the median survival, because in my experience, now the median survival is beyond 16 years. You remember, we started at 6 years in the classical literature. Why? Because I did more and more supratotorization, namely to remove more than the flare visible on preoperative MRI, because everyone knows that this is a diffuse glioma, so you have tumoral cells beyond what we can see just on the machine, on the MRI, on the imaging. And what happened in this series, no patients died, no malignant transformation, no radiotherapy, no more quality of life. So that means that we can change radically the natural history of the disease, even if more than half of patients had a recurrence. So I never said that I was able to cure patients, but I can avoid malignant transformation. And of course, the goal is to arrive earlier and earlier in order to increase the number of patients with smaller tumor initially, and then to increase the rate of supratotorization. We published recently in Journal Neurosurgery, but also you will see next slide, Neurosurgery, the first 100 patients operated on with incidental diffuse low-grade glioma. And now we have a 30% of supratotorization plus 30% of complete resection without margin around. So more than 60% of total supratotorization with no adjuvant treatment, despite the fact that there were already 30% of malignant foci, no epilepsy, no deficit, and 97% of them return to a normal life, including able to work, which is absolutely critical if you want to be preventive. And this is the reason why we propose the screening at the general population. We can discuss about that, of course, but we started to operate some patients with intentional discovery of possible asymptomatic tumors. We can do that because we know the limitation of neuroplasticity. We published in that class about that. You can use it if you want. It's in the MNI template telling you if you remove more, then you increase the risk to have this kind of deficits. And this is the reason why sometimes we know the limitation of the compensation of the brain, and we know that it's not possible to remove both SLF, for instance. So the goal is to do, in these cases, neoadjuvant chemotherapy to induce shrinkage independently of the molecular pattern, and to reoperate in order to preserve the quality of life, which is possible only if you know this minimal common brain, namely, is it possible to remove more or not? This is true for surgeons, but this is true also, it should be true for radiotherapists, because we have the habit to do too early radiotherapy for nothing, to induce permanent cognitive deficit after 5 years while they are living 20 years, and finally to say now we cannot re-irradiate because it's too late. So we proposed a few years ago a new paradigm by telling you have to operate first, to reoperate by inducing plasticity in the meantime, thanks to postoperative cognitive rehabilitation. If you cannot, to do chemotherapy, because with no adverse effect regarding the cognitive functions, even 15 years later, because we have the objective data about that. And finally, to give radiotherapy before malignant transformation, of course. And thanks to this model, we will publish another paper about that, thanks to the experience in Nancy, a small city in France, but with a big recruitment. And we have the habit to deal altogether for 20 years, median survival more than 16 years. And you can postpone chemoradiotherapy even if you identify some fossil malignant transformation in the middle. We published that in Neuro-Oncology this year with a 5 years survival rate which is 95%. For instance, here, 22, I decided to do surgery with extensive resection, no chemo, no radiotherapy. And finally, I redid another surgery just 3 years ago, and no chemo, no radiotherapy. It was a high grade initially. It was a low grade 3 years ago. Of course, because I removed only the part which was aggressive initially without chemoradiotherapy. So the best message is to tell you, neurosurgeons, you can change radically the natural history of the disease if you do a resection according to this knowledge of the connectome. So in other words, you have to publish as a neuroscientist in this kind of papers, also journals, by telling, we know the functional connectome better than neuroscientists because we are connected every week to the brain of human beings. And this is the reason why, to conclude and to help younger neurosurgeons, we published recently the third atlas in the literature with the knowledge of the cortical and subcortical networks critical for the function regarding 16 different functional domains, not only movement, language, but also semantics, behavior, and so on. And it's in the MNI template based on almost 2,000 stimulation sites. So that means that you can use it in order to better pre-plan your surgery if you want. And finally, we modeled not only the right, the left hemisphere, but the interactions in between. And we proposed recently, so in physiological reviews, this concept of not only within, but also across system integration, namely to better understand the dynamics between subsystem and subnetworks. Why? It's critical because it's exactly what we are doing into the operating theater when we stimulate. Namely, if you ask a patient to name and to move, very basically, the patient sometimes can stop to name. You will say, this is the language network. Sometimes stop to move or dystonic movement. You will say, this is the network dedicated to movement. But sometimes you can block the interaction between, and the patient is still able to move, still able to name, but not able to do both simultaneously. This is a desynchronization within the meta network. And you will say, but is it really critical? Yes, if you want to be a human being. I will not have time to show you movies, but just to tell you, for instance, that in this very extensive diffusion in patients with incidental discovery, according to this concept of connectomal-based resection, you can go through Broca's area, you can remove extensively the tumor to avoid chemoradiotherapy in patients with no normal life. She's a medical doctor. So just to conclude, my next paper in neurosurgery will be that we have not to think about the glioma into the operating theater because this is a diffuse tumor, but to think about the brain. And it's not expensive, especially in Pakistan, to know the brain, to do intraoperative cortical, subcortical mapping and cognitive monitoring. It's very cheap. You can do that more or less in all patients, of course, if they are not arriving too late, and to do resection according to the knowledge of the connectome without any technology, with 99% of reliability, less than 1% of risk to induce severe permanent deficit, and to triple the median survival. And I hope it's not, of course, the end, because we will continue to re-operate these patients low-grade glioma. So my message is, now you have the choice just to treat a tumor according to the protocol, like an oncologist, or to take care of a human being in front of you by understanding his brain, which will evolve throughout the decades, normally like yours. Thank you very much.
Excellent.
Thank you, Dr. Hughes. Our next presenter is Dr. Jack Rock. Dr. Jack is a neurosurgery specialist and from 2002 onwards has directed the neurosurgical residency program at Henry Ford Hospital in Detroit, Michigan, and is the current interim chairman of the department. His primary subspecializations are neuro-oncology and pituitary and skull-base surgery. Today, he'll be speaking on anterior cranial base and cellular surgery. Over to you, Doc.
You're mute, Dr. Rock. Dr. Rock, you're still mute.
Can you hear me now?
Yes.
Okay, good. So let me just shoot. Let's try this. Are you able to see this yet? Can you see this?
Yes.
Are you seeing this? Am I on? Do you see the first slide?
Yes,
Yeah.
we do.
Okay, good. Sorry. Okay, well, I'm feeling a little intimidated following that very scholarly presentation by Dr. Defoe, but what I'll do is I'm going to present just our personal experience here at Henry Ford Hospital and what has evolved over the years from a craniotomy approach to these anterior skull base to an endoscopy approach. And so I'll show you a couple of the complicated cases a couple of the mistakes we made and what we feel is really the way we can solve the problem virtually, well, not virtually like on a computer, but virtually we can solve the problem of CSF leaks. So our own, let me just move this over here. Okay. So our own experience, esthesioneuroblastoma neuroblastoma is not a very common case, but we see those. Suprasellar meningiomas, subfrontal meningioma, but the majority of what we treat here in Detroit is pituitary adenomas, some Rathke cysts, and some craniopharyngiomas, and pituitary is really the majority of what we treat here. The transition between the craniotomy and the endoscopy approaches really revolves around the anatomical understanding of these two slides. And obviously we're all familiar from our training and experience with the typical subfrontal image here. Getting this image in your mind and understanding the subtleties of this image is what makes it much more easy to go about doing these surgeries from a transnasal approach. And the key findings that it certainly took me a while and probably a lot of folks is understanding the difference as you look in with an endoscope at the base through the nose. You see the sella, which looks gigantic compared to the way it looks with a microscope. And now you see the optic nerve here and the carotid artery here. And this structure here, the lateral optical carotid recess, really the equivalent of the optic strut here when we look from the other side. So once this becomes a more familiar anatomy, it becomes much more easy or comfortable for the surgeon to be working from below. Suprasellar meningioma, I'd have to say, I know that Dr. Gardner and Prabhadella and Miranda and many people internationally are doing these kind of surgeries endoscopically. We're really just starting to do surgeries like this endoscopically. Some of my concern of that has been, let me jump to here, is a tumor like this that we did subfrontally, the extension of the tumor laterally over the anterior clinoid process has limited my comfort with doing these endoscopically. So if the lesion is truly centralized between the optic nerves, then we're comfortable considering this operation as an endoscopic approach. But generally speaking, we still do the majority of our subfrontal meningiomas and tuberculin meningiomas, diaphragmocellular meningiomas as a subfrontal approach. Transphenoidal surgery obviously is the lion's share of what we do here in the endoscopic world. The typical, I'm not going to show you a lot of pictures of pituitary surgery because I'm sure you probably all have enough experience with that. We typically have our typical endoscopic approach now this way. We don't have the 3D endoscopes yet. We're trying those, but the resolution on them in the past has not been optimal. And so we've stuck with the regular endoscopes. But here's the main thrust that I wanted to go over with this presentation is to go over a couple errors we've made and how we do now with craniopharyngioma and with Rathke's cyst. The Rathke's cyst is a typical lesion. Typically it presents with a headache, visual loss. Seizure is pretty rare in my experience. In fact, I don't think I've ever seen someone with a seizure from a Rathke's cyst. And the other hormonal syndromes from the pituitary tumors, but we'll stick with the Rathke's. Where I trained with Dr. Russell Patterson at Cornell, now many years ago, we did craniotomy for all lesions that looked like this. That converted over to microscopic in the 80s, late 90s. We're converting into endoscopic assisted, and more currently, these are all endoscopic approaches. The Rathke's cyst is typically a benign lesion. It's endothelial lined. It doesn't constitute a high percentage of pituitary or cellular lesions, but it has a very high recurrence rate. So complete symptom resolution is common, but the problem is if you don't resect the entire cyst, or at least the majority of the cyst wall, you're going to be left with a fairly significant chance of recurrence. So this is a patient who has a Rathke's cyst. You can see the optic chiasm elevated in this patient presented with bilateral visual problems, hemianopsias. This is the coronal view, and this is post-op. But here's the mistake, because when we look at this, and I hope this video will play, can you see the video? Okay, we're looking here.
Yes, we can.
Here we are, the CSF. Here's the CSF is being released. We've opened the planum up to here. This is the top of the sella and the top of the pituitary. We go above. We've cut the intercavernous vessel vein, and now we're looking above. So we'll then stop here. I'm going to cut up to here. Now we're looking at the Rathke's cyst, and we're cutting a hole in the cyst. Now this is going back about 15 years ago, and the biggest problem we had here is we really didn't have very good equipment at that point. We have very good equipment now, that we don't have bipolars that barely fit down the channel of the nose to this kind of a depth. We have the small scalpels, which make this very easy to remove most of this lesion. And so when I had removed most of this lesion, and I think I can jump to here now. Oh, let's go back one. Down here. Now we're seeing the hole that was made. We're looking in now actually with an endoscope, and we look up and we can see in the back here the haziness of the optic chiasm. Nowadays, we would never do this. We would expose much more widely. We'd expose the optic nerves up here so that we don't guess about where they are, but we actually see them. This is too small a hole in this patient, and this is the reason this patient recurred. When we look at how we closed things 15 years ago, and comes from Dr. Ted Schwartz's articles in how I was closing this before the nasoseptal flap, we would actually take a piece of Medpor and we put a piece of allograft over the hole that we had made, and we tap this piece of Medpor into the hole that we had made to do the entire exposure. And this did work very well, but is really, I would have to say, is no longer necessary, and we never do this anymore. I'll show you in a minute really how we do close things. I'm going to take a risk here and downsize this one and show you this slide presentation. Let me see if I can do this. Okay. This is a series we had. Can you see this slide now?
Yes, we can.
Okay. This is the series we've had in the last couple of years, and we've had 80 CSF leaks for various reasons, spontaneous leaks, but many of them high flow or low flow leaks from the transnasal surgeries. the way we do this now, this would be our typical opening, about 1 centimeter by 2 centimeters. We put in, this is probably just some not a flow seal in there. We don't think that the flow seal constitutes any kind of reasonable seal. Then we take Biodesign, which is a porcine intestine material. We put it underneath as best we can, and I can tell you, I'm going to stop this here for 1 second. This, I'm sorry, let me get one back here. While this looks really good, it's not common that it looks this good, so I'll just tell you this is ideal. It doesn't always look this way. We put sometimes, most of the time, a vascularized nasal septal flap, but on occasion, if there's not a big leak, we'll put in just a piece of mucosa, and then we cover this with adherus, which is a material like Duraseal, and this is generally what it looks like now about 6 months later after, or this is 3 months later in our ENT clinic. So let me now get out of this presentation and come back to here. Okay. So this is the overall change that we've had that makes our ability to tell a patient that we will have a little to no, less than a 2% actually over the last 5 years, risk of a CSF leak, and the 2 patients that we had, neither one of them required a surgery. It was lumbar drainage for about 5 days and they sealed. So moving on to craniopharyngioma, we all know the background of craniopharyngioma, 1 to 4% of intracranial tumors. I would have to say that many of our craniopharyngiomas we still do transfrontally, but we've made a transition in the last few years to endoscopic. This started back around 2010. I don't do all of them endoscopic. We don't have many craniopharyngiomas every year, but we do have some. And so as we move into this, the transcranial, this is a paper that came out of UVA. Obviously, the open transcranial approaches are associated with a little higher morbidity, but as you can see from this transsphenoidal and endoscopic, pretty low rates here for any kind of problem with stroke or hemiparesis. CSF leaks are pretty common, or they were, but I can honestly say that with our experience, we're down to certainly less than a 5% chance of a post-op CSF leak after the nasoseptal flaps. If we look at a typical, this is an interesting way to look at, this was a large craniopharyngioma, and by the time we finished the surgery, and we did this not only subfrontally, but we split the falx, and so the view we get from this kind of operation allows us to see through the lamina terminalis. We can come, if the tumor is a little bit more under one optic nerve than the other, we don't have to put our suction and retract on the optic nerve. We just move from one side view to the other side view, and we can have a nice way of pulling the tumor out from underneath the optic nerve without retracting the optic nerve. So that's transfrontally. Once we get comfortable with this approach, then we have a tumor, something like this. The ENT team works with us throughout the entire operation. We have 4 hands on this. We have much better equipment now, most of which we got from Dr. Prevadella's surgical pages. And it's very nice rotating tip bipolars and rotating tip scissors, which make the surgery infinitely easier. We have a tumor like this, nice one to show because most of it's a cyst up here, so it makes you look like a better surgeon than you are, but still it winds up, here's what we look at. We see the optic nerve, the lateral opticocarotid recess, and the carotid artery and the sella. These are just the plain pictures. And this, after the resection of the tumor, is looking up into the 3rd ventricle. And so I can show you here, we pull out the major portion of the tumor, and it's kind of a relatively satisfying video. And then once we get in here a little deeper, We can look in a little bit more tumor there. I think for the interest of time, I'm going to skip over to this slide. Now we're looking in, we can see this view, which shows the floor of the third ventricle, the foramen of Monroe up here, and the mammillary body in the back. And we're fortunate enough in this particular case, of course I wouldn't put a terrible case up here, but I mean it was fortunate enough that we can see the anatomy. The capsule comes off, which is, I can say, is absolutely not always true. And so then we see the intrathalamic adhesion. And so you can have a very nice view. And I really actually prefer the transnasal approach for the craniopharyngiomas, but not for very large tumors, not for tumors that extend laterally away from the midline. These are for essentially, in my hands, it's for midline tumors. And when I have those kind of cases, let me go back one final video and then we're almost at the end here. So here's a craniopharyngioma case. The nice thing about this is we come, I'm going to skip through the ENT part. Dr. Craig, my rhinologist, would be shocked that I'm skipping here, but I'm going to skip through here and you're going to see where we get down, lateral optical carotid recess there. And now we have our opening. We open into the cella, into the, through the planum. We're looking at this tissue up in here, which is the craniopharyngioma. We're going to see this vessel, which proved to be a complete annoyance through the whole operation, but because it looked like an inferior hypophyseal vessel and I couldn't tell if it was going to the chiasm, I didn't want to risk it, so we worked around it for the whole case. You just keep debulking, you keep taking little pieces where they come. We have very nice tools. I keep saying that because it was a torture doing these operations when we didn't have good tools. But with these newer pieces of equipment, you can really get around structures. You're not bumping into everything. You can cut things gently off the optic chiasm. And then when we get to the back, let me just jump to the end here. We're looking at the mammillary body, basilar tip, and then we can look, I think, up into there. Let me just cut to here. We're looking in at the hole that we have to make. This would be considered a high flow leak. We don't, I mean, we do it multi-layer, but we put in some Duragen on this case. And I think if you ask me honestly, I think every time we do the surgery, we have a somewhat different way, but basically we use this biodesign. It works very well. I'm honestly not sure we need to use biodesign because a good vascularized nasoseptal flap seems to be working for most people around the country here. Once we get in the biodesign, we then would put, let me skip up here, the nasal septal flap gets laid in there at the end. We cover it with adherus, and that is essentially what we do. I think the vascularized nasal flap has obviously revolutionized this transnasal surgery. We have a microvascular Doppler available if we need be to find the carotid when we're drilling through the bone. And so overall, in summary, we still do a lot of craniotomy for these subfrontal approaches for these planum meningiomas. If they're small tumors, we'll do it endoscopically, but if they're larger tumors, we still do it transfrontal. I'd have to say the learning curve, I trained as a typical neurosurgeon 30 years ago, actually. I hate to admit it, it's actually a little more than 30 years ago. But in any case, I trained that way with craniotomy, so learning this technique with endoscopy was a challenge for me, probably less so now when you have teachers like Prevedella and Paul Gardner and Miranda and many others. So people are coming up very well versed in technology to do this. Skull-based defect was the big problem. It no longer is, I can safely say. I still think for rachis and craniopharyngioma, if it's midline tumor, endoscopic is the best approach. And we're still not to the point of doing the subfrontal meningiomas endoscopically, at least with the larger ones. So that is it. I appreciate the invitation to be part of this session. And I do remember when Dr. Inam was a resident, excellent technical surgeon, nice sense of humor. And when he was up there at the local hospital in Detroit covering the back pain patient, or back pain patients at the service at Macomb, I remember covering for him on the weekends. So thank you, Arthur.
Thank you, Dr. Jack. Our next speaker for this evening is Dr. Jinsong Wu. Dr. Jinsong is Professor and Vice Director of the Glioma Surgery Division, Neurosurgery Department of Huashan Hospital at Fudan University, China. Dr. Wu has been established as an academic leader in Chinese neurosurgery and has developed his own novel integrated technical system for multimodal brain mapping strategies, and has also established a Chinese language cortical distribution atlas. Today, he'll be speaking on the dominant side insular glioma surgery. Over to you, doctor.
Thank you. Can you see the slides? Can you hear me?
Yes, we do.
Yes, we can, sir.
Thank you very much. It's my great opportunity to give a talk here today. So first of all, I want to show my respect to Dr. Arthur Inam. And 2 years before, he visited our department in the spring. So I still remember the party when he visited Shanghai. I hope everything will become normal after the disaster. So today my topic is about the insular glioma surgery. So today, totally I have 4 topics. The first about applied neuroanatomy. Second is about the perisylvian cortical mapping results. And the third, I want to show an illustrative case, a surgical video. And finally, I want to talk something about the outcomes and the complication in consecutive case series. So when we talk about surgery, what do we really talk about? Yes, I think it's anatomy. So when we talk about surgery, we should talk about the anatomy behind our surgery first. So the insula belongs to the mesocortex. In another way, the insular cortex before the central insular sulcus belongs to the mesocortex. The cell can be divided into 6 layers, but the granular cells are much less than the true isocortex. This set of illustrations shows the different anatomical characteristics of insula and the surrounding brain structure from lateral to medial. In the process of brain development, the insula is rolled up inside the frontal, parietal, and the temporal cortex. The frontal lobe that covers the insula is the middle and the posterior part of the inferior frontal gyrus, which is also called the frontal operculum. From rostral to caudal, it divided into pars orbitalis, pars triangularis, pars opercularis, and ventral part of precentral gyrus. And this is the temporal operculum, the middle and the anterior and the middle part of superior temporal gyrus. And here you can see the parietal operculum, part of the ventral posterior central gyrus and anterior part of the superior marginal gyrus. So all the insular cortex was covered by the frontal, parietal, and the temporal operculum. The insula is divided into 3 short gyri, 1, 2, 3, and 2 long gyri. The 3 short gyri converged at the apex of the insula here. The apex is the most extensive part of the insula, corresponding to the anterior sylvian point. Between the long gyri and the short gyri is the central sulcus of the insula. It extended forward and downward to the Lyman insula. The Lyman insula is the anterior and the inferior boundary of the insula. Well, the M1 segment of the middle cerebral artery divided into the frontal branch as well as the temporal trunks. The frontal trunk is mainly distributed in the lateral surface of frontal lobe, and the temporal trunk is mainly distributed in the temporal area. The terminal branch of the middle cerebral artery points to the posterior silver point. Well, it distributed to the supramarginal gyrus as well as the angular gyrus of the inferior parietal lobule. The front edge of the insula is the anterior insular limiting sulcus, and at the up edge of the insula is the superior limiting sulcus, and the inferior edge of the insula is the inferior limiting sulcus. Three critical points. The first one is the meeting point of the superior limiting sulcus and anterior limiting sulcus, which called anterior insular point. This is an isthmus of the basal ganglia. So the anterior insular point very close to the caudate, the head of caudate, as well as the frontal horn of the lateral ventricle. Another critical point is the posterior insular point. It is another isthmus of the basal ganglia. It is the meeting point of the superior limiting sulcus and the inferior limiting sulcus. So it is very close to the ventral, to the atrium of the lateral ventricle, as well as the pulvinar. The third critical point is the Lyman insula. Here, in the side of the Lyman insula is anterior perforated substance. So there, the M1 segment of the middle cerebral artery originates the lenticulostriate artery, penetrate the ventral striatum, and supply the basal ganglia and the internal capsule. The main gyri of the frontal and the temporal operculum between the sylvian fissure include the subcentral gyrus and the transverse temporal gyrus. The subcentral gyrus is related to the speech production, and the transverse temporal gyrus is related to the hearing. The surface cortex of the insular lobe include the inferior frontal gyrus, the ventral part of the central lobe, the anterior part of the superior marginal gyrus here, and the superior temporal gyrus. The main foci include the stem part of the sylvian fissure, the lateral part of the sylvian fissure, the horizontal ramus of the sylvian fissure, the anterior ascending ramus of the posterior ascending ramus of the sylvian fissure, and also the inferior segments of the precentral, central, and the postcentral foci, and the ascending ramus of the precentral, central, and the postcentral foci. Of course, there is another critical foci is the superior temporal sulcus. In case we perform a simulated surgery on the cadaver brain, fistulation of the pars triangularis can reveal the first short gyri. You can see here, the first short gyri. Further resection of the pars triangularis, pars orbicularis can reveal whole three short gyri, and the resection of the pars orbitalis can expose the anterior limiting sulcus. Resection of the superior marginal gyrus can reveal the posterior insular point and the retroinsular region here. Cutting the ventral part of the central lobe here, you can see the two long gyri of the insula. if you want to keep the ventral part of the central lobe, you can also expose the long gyrate of the insula as well as the posterior insular point from rostral to caudal after short gyrate are removed. The frontal operculum was removed to the level of inferior frontal sulcus. So the inferior frontal sulcus is corresponding to the superior limiting sulcus of the insula. The temporal operculum resection can review the ventral part of the insula to the level of the inferior limiting sulcus here. In the cross-section of the superior limiting sulcus, you can see different white matter tract. Here you can see the superior longitudinal fasciculus part 3 pointing to the frontal operculum. And you can also see the superior longitudinal fasciculus part 2 pass over the superior limiting sulcus. So beneath the inferior limiting sulcus, there is the internal capsule and also the body of the caudate nucleus. In the cross-section of the frontal operculum, you can see from lateral to medial, you can see this is the pars triangularis, pars opercularis, and here you can see the transverse temporal gyrus. The first branch of the transverse temporal gyrus is obviously raised and slender. This is also called hagiogyrus. And from lateral to medial, you can see the cortex, the insular cortex, the extreme capsule, the claustrum, the external capsule, the putamen, the internal capsule. Here is the granule, and also the head of the caudate. In the cross-section of sylvian fissure, from lateral to medial, you can see here is the temporal operculum, inferior limiting sulcus. Here you can see the apex of the insula, which was the converge of 3 short gyrate of the insula, and the 2 long gyrate. Here is the posterior insular point very close to the atrium of the lateral ventricle. And there you can see the anterior insular point. And the extreme capsule, claustrum, external capsule, putamen, a globus pallidus, internal capsule, and the thalamus. And here you can see the caudate, the head of the caudate nucleus, and the frontal horn of the lateral ventricle. In the cross-section of inferior limiting sulcus from lateral to medial, you can see the transverse temporal gyrus, the Lyman insula, and of course you can see the ventral part of the striatum. Here is the anterior perforated substance, nuclear accumbens, and the substantial anomenate. And here you can see the globus pallidus, internal capsule, and also the thalamus. When we want to protect the brain function, the essential is not only the protection of the cortex, but also the protection of the subcortical white matter pathway. Therefore, we must have a clear understanding of white matter fiber dissection. This photo shows the classic white matter fiber dissection using Klink technique. The acute fasciculus and the superior longitudinal fasciculus part 2 and part 3 surround the superior, posterior, and the inferior margin of the insula. Under the insular cortex, you can see the U-shaped fiber. Inner layer is the external capsule, which consists of the uncinate fasciculus, inferior frontal occipital fasciculus. Here you can see the gray matter. This is the claustrum, and above the claustrum is the claustral cortical fiber. So this is the whole view of the external capsule. In this picture, you can see the uncinate fasciculus, inferior frontal occipital fasciculus. And after removing the putamen, you can see the internal capsule, which connect the corona radiator upward and projected to the cerebral peduncle downward. After removing the putamen, you can see clearly the internal capsule here. And the backward it is the sagittal striatum, which comprise the anterior and the optic radiation. Here you can also see the anterior commissure. This is the globus pallidus, internal capsule, corona radiator, and the anterior commissure. Here is the optic radiation fibers. So to our knowledge, the classic dorsal language pathway include the acute fasciculus, superior longitudinal fasciculus, part 2, part 3, part TP, as well as the frontal arsenal tract. And the ventral language pathway, the ventral language stream, comprise the I4 inferior frontal occipital fasciculus. This is the direct connection of the language comprehension pathway. And another indirect pathway is the uncinate fasciculus plus inferior longitudinal fasciculus. So the main veins on the surface of the insula include the superficial sylvian vein, the deep middle cerebral vein, the vein of Cholin, as well as the vein of Labi. The M2 and the M3 segments of the middle cerebral artery pass through the surface of the insula. The M4 segment is lying on the surface of the insular operculum. There is the anterior perforated substance beneath the deep surface of the Lyman insula. So on this image, you can see clearly the lenticulostriate artery from the M1 segment penetrates vertically upward and supplied the basal ganglia and also the internal capsule. The second topic is about the parasylvian cortical mapping result. This slide shows the classic model of the left parasylvian facial language cortex. As we know, it can be divided into the broadcast area, which is responsible for the language production, also called phonological encoding, and the ventral part of the central lobe, which is responsible for the phonetic encoding as well as the articulation. And here is the facial gyrus, the first one of the transverse temporal gyrus, which is responsible for the auditory. And here is the posterior part of the superior temporal gyrus and the part of the middle temporal gyrus, which also called the Wernicke area. It is responsible for the language comprehension. These slides show the scattered distribution map of language localization positive sites in Chinese population. The positive localization results from a total of 185 cases. The red dots indicate the speech arrest, the yellow ones indicate anomia, the blue dots indicate ataxia, and the green dots indicate articulation deficit. We can also reconstruct all the ventral and the dorsal language-related white matter pathway separately and provide a 3D visualization in a VR environment. MR diffusion tensor imaging can be used for individualized visualized language pathway, including dorsal stream as well as the ventral stream, and also the motor pathway, corticospinal tract, to guide individualized surgical planning and intraoperative real-time tumor resection. Now I want to show you an illustrative case surgical video.
This video illustrates a dominant left insular low-grade glioma performed under awake mapping. A 37-year-old male patient who is right-hand dominant presented with intermittent numbness of the right extremities over a year. There were no significant findings in the initial physical exam. CT scan indicated a heterogeneous low-density left insular mass, which was hypointense on T1 weighted sequence and hyperintense on FLAIR sequence, with no significant contrast enhancement. MR spectroscopy detected increased colon and decreased NAA composition, and the maximum colon to NAA index was 1.8, suggestive of neoplasms. Diffusion tensor imaging tractography was used to perform motor and language fiber tracking, various eloquent subcortical fibers adjacent to the lesion. Functional MR revealed motor and language activation cortex. These process data were crucial for pre-surgical planning and exported to the intraoperative navigation system. The patient was placed supine with his head turned 45 degrees contralaterally and the neck slightly extended to facilitate good venous return. A bone flap was tailored according to the neuro-navigation imaging. Tack-up sutures were placed around the edges of the bone window. The patient is then awakened and subsequently mapping is performed. Upon opening the dura, a 6-contact strip electrode placed directly on the cortex was utilized to identify the central sulcus by polarity reversal of the median nerve SEPs. Stimulation was then performed over the entire exposed cortical surface, using a bipolar electrical stimulator probe to identify motor and language cortex. These positive sites were labeled and covered. Neuro-navigation was used to precisely mark the boundaries of the lesion. The arachnoid was dissected and were protected. In non-eloquent areas of the inferior frontal gyrus, fistulation of the cortex was performed to expose the insula. The neuro-navigation system was implemented throughout the surgical procedure to not only help the surgeon determine the extent of tumor invasion, but also help identify important anatomical structures. CUSA was used to gradually resect the tumor beneath the frontal operculum. Throughout the resection, the patient was routinely tested for speech, sensory, and motor function, especially when resection was adjacent to the eloquent cortex or pathways. Tissue samples were sent for frozen section. The results suggested low-grade glioma. The temporal operculum was fistulated in a similar fashion for further resection of the insular lesion in zones 3 and 4, according to the Berger-Sinai classification. The MCA bifurcates at the Lyman insula, forming various M2 branches on the surface of the insula. Resection should be carried out in between these vessels, and the tissue selection parameter of CUSA was set above 3 for vascular protection. Positioned deep to the insular cortex are the extreme capsule, colostrum, putamen, the external capsule, and the internal capsule. Subcortical stimulation was performed to identify language pathways using a monopolar probe. The uncinate fasciculus, the inferior frontal occipital fasciculus, all close at the same depths under the inferior limiting sulcus. The lateral lenticular striate arteries, which supply the internal capsule, putamen, and globus pallidus, should be spared. Electrocoagulation should be avoided if possible. Continuous language and motor subcortical mapping for identification of the internal capsule and cortical during resection of zone 4 tumors is very important. The temporal horn was exposed. The resection cavities were rinsed repeatedly with warm saline until hemostasis was achieved. Then, surgiflow was injected into each cavity. Intraoperative MR suggested approximately 95% removal of the lesion, achieving the pre-surgical planning goals. The bone plaque was restored and routine closure was carried out. The histopathological diagnosis was astrocytoma grade 2. The molecular pathology revealed IDH1 mutant GMT promoter methylation. These results suggested that the patient has a relatively good prognosis and is chemosensitive. Therefore, no adjuvant radiotherapy or chemotherapy was necessary. The patient was stable at the 6-month follow-up, and the imaging evaluation results were satisfactory. The patient's cognitive function returned to the preoperative baseline level.
So finally, I want to show some data of the outcomes and complications. So we studied 255 consecutive cases of insular glioma surgery underwent transcortical tumor resection in our department. So in total, 172 patients had an extent of tumor resection larger than 90%. And the radiotumor location most likely located in the superior perinsular region, posterior insular point, and the putamen region. And extent of tumor resection is an independent predictor for overall survival in both high-grade and low-grade cases. The post-operative permanent neurological deficit is about 50% among 172 patients. Vascular infarction is the leading cause of disability of insular glioma surgery compared with direct injury of motor and language pathway. So in conclusion, I believe the multimodal brain mapping technique in combination with the transcortical surgical approach is very confident for the insular glioma resection. Thank you so much for your attention.
Thank you. You're mute, Namra.
Sorry. All right, thank you, doctor. I'd like to repeat before we move on to our next presenter. If anyone has any questions for our speakers, you may ask them on onlinequestions.org by entering the event number 13419. All right, so our next presenter is Dr. Konstantinos. Dr. Konstantinos is a professor of neurosurgery and oncological sciences at the Icahn School of Medicine at Mount Sinai. He serves as chair of the Department of Neurosurgery at Mount Sinai Union Square and is also director of the Mount Sinai Brain Tumor Nanotechnology Lab in the Tisch Cancer Institute, where he studies novel therapeutics targeting brain tumors. Today, he'll be talking about patient outcomes in glioblastoma multiforme using a robotic-assisted digital surgical exoscope. Over to you, doctor.
Thank you. Good evening, everybody. Can you hear me okay?
Yes, we can.
Excellent.
Costas, can I add one thing? So the question and answer session is at the end, so that we all know.
Okay.
The questions that are coming in are being just stored, and at the end of the session, we will ask the questions from the speakers. So please go ahead, Costas. Thank you.
So I just want to say thank you to Dr. Athar Anem and the entire Pakistani Neuro-Oncology Society for being part of this first annual symposium. It's exciting and it's great to see things are alive and well in that part of the world. And sorry we can't be with you physically, but we're there with you today on Zoom. So today I'm going to talk a little bit about our initial experience using the exoscope for our glioblastoma patients. I do want to disclose I am a consultant for Synaptive. I've been working with them for years, helping them develop their platform, and happy to report on the latest iteration of their technology. Here I just want to summarize my presentation, briefly talk about extended resection. I think Dr. Dufault and others have really done a nice job kind of discussing this, so we won't spend much time, but go into a little bit about visualization, magnification, tractography, and some of our current conventional microscopy approaches, and then of course introduce the robotic assisted digital exoscope and a paper that we recently published on our outcomes utilizing this technology in GBM patients. So I think we can all confidently say that the greater the extent of resection for high-grade gliomas, the better our patient outcomes. And I think that extends not only for survival, but also involves progression-free survival and also allows for better efficacy of our adjuvant therapies. The challenge, however, is how invasive these tumors are. And we know that the infiltrative margin of gliomas extends centimeters away from the contrast-enhancing border. So our surgical paradigm really addresses the contrast-enhancing portion of the tumor. However, we know there's tumor cells that extend considerably beyond this border, as you can see here, and based on studies done decades ago by Pat Kelly, actually at NYU in New York City. So these are real challenges. I mean, I think visualizing the tumor well and seeing the infiltrative border well are some of the hurdles that we face with glioma surgery. And we used various technologies, and Dr. Dufault discussed his awake craniotomy approaches. He does not use navigation, microscopy, et cetera, and others do rely on microsurgical type approaches, neuronavigation, and mapping, and even ultrasound has been important with intraoperative MRI in some centers. The concept, though, is really how do we see things better? And this is a nice slide I show of a visualization through a window in a Greek island in the Aegean. You can see here the nice mountainside, the Mediterranean here in the distance. And, you know, we operate through various windows through the cranium to see what we're doing. And it's important that we have clarity and really are able to delineate the pathology that we're working on. But certainly magnification is quite important too. And this is that same island from our apartment here my family stayed at last year. Unfortunately, we can't make it to Greece this year. The EU won't let American citizens fly to Europe because of our COVID situation. But you can see this nice yacht in the distance in the Aegean, the nice blue Aegean. And in the back of the yacht, there's what appears to be a smaller boat that you can see, not quite well. And of course, if you magnify your view, there you see it. You could see the small other boat in the back of the yacht. Our current approaches rely on binocular optic microscopy. This is one of our prior fellows. He was at the BNI, he came to Sinai, and now he's at Rutgers. He's really done a lot of work with optic imaging of Yeni Belik. you'll hear about him in the coming years. He's really great and promising. And this is kind of the challenge that we work with as, in our microsurgical approaches. We angle our necks, we angle the optics of the binocular system, and try to magnify and see what we can in order to perform our surgery safely. But there are some challenges with optical microscopy, and one of them is the limited magnification possible because of the optical lens and binocular view. Other challenges that we encounter that some of us may or may not appreciate is the glare of the light, and how the image quality could be at times not optimal. And of course, the view is confocal, not panoramic. And there's new technologies that have evolved through the years, and the exoscope has been around for quite some time, and of course the endoscope has been around for decades, and these technologies allow us to appreciate a more panoramic view. And with the exoscope, the newer generation exoscopes, now we have a digital image that can now be enhanced and processed. You cannot enhance and process an optical image. You can overlay things on that, but you can't enhance the actual colors and view of that image. And of course, the exoscope has provided greater magnification and clarity, and it allows us to position the device in order to see for us instead of us using our necks and moving our heads. And this is just some of the concept I'm trying to show to you between a panoramic and a confocal view here on the lower illustrations. So the Modus V is a device that Synaptive had released a little bit ago. And is really a robotic-assisted exoscope. And the newer device now is also 3D capable. And we've been using this now for the 3D version we just started using last fall. And of course, the 2D version we've been using for several years. But it also combines some other types of technology like neuronavigation, whole brain tractography. And the arm is robotic and moves with your pointer and also as you grab the arm. And of course, there's a voice-activated control function now too. And this is just some video, and we're going to get into some other views here, but of a posterior faucet lesion. You can see how nice it is visualizing the lower cranial nerves and allowing for dissection. The optical zoom is 12.5x compared to the 6x of the standard microscope. So that's quite a substantial change and difference that's capable. And of course, the resolution is quite good. And the field of view is actually twice compared to the microscope. An LED light is used instead of a xenon lamp, which the microscope relies on. And the intensity is much lower with the LED light, usually on the order of 15 to 30%, where we normally would use the operative microscope above 60%. So that's something that I've appreciated and learned from with our experience here. And of course, the microscope is our workhorse. This is not a lecture to put down the microscope. This is a lecture to just introduce and discuss a new technology that we all should consider as we move into the digital age. One of the things that I've enjoyed using with the exoscope is how I think the magnification and clarity may allow for better delineation of tumors. And this is a high-grade glioma case where you can just see the brilliant display and clarity of the tumor that's highlighted by the white arrows. And then, of course, we have the ability to use this device in 3D now and dissect gliomas off. You can see the ICA bifurcation here and really do this confidently. The 2D approach is a little more difficult. This is a 2D view. You can't see 3D here, but this was a low-grade glioma that was basically encasing the MCA and the ICA bifurcation. We combine tractography with this technology. You can see here the subcortical large high-grade glioma displacing the tracts medially. And of course, this is something that we combine with cortical and subcortical mapping so that we can also ensure that we resect the tumor in a safe fashion. You heard the talk before with some really nice illustrations. The other thing that's interesting is that the ergonomics and surgeon comfort is something that I've appreciated more now as I get older. My neck, my back, these are things that we feel more as we move into our careers. we're not young guys anymore. And I think these are some of the concepts that the exoscope can help us determine whether there's more surgeon comfort and better overall stance in regards to surgery with the heads-on display and the upright posture. So some advantages that I'm going to discuss, and we'll get into some more details here, but I do believe that I enjoyed using this device for visualization, magnification, combining it with tractography and neuronavigation. The robotic movement and positioning is nice and helpful. I don't know if that's the defining part of this technology, but I also believe that engagement of the team is important too. And that becomes quite important with education of our residents and our surgical team. But these things all translate into what I feel could account for better delineation of the lesion, understanding of surrounding eloquent tracts for surgery, and could translate into better hemostasis and, of course, education. So, of course, there's also a learning curve here. And I believe that in our newer generation of neurosurgeons who are growing up, Jack gave a nice lecture on endoscopy. And, I grew up at the University of Pittsburgh where I did my residency, and that was something we did routinely. And I think as our neurosurgery residents learn endoscopy more and more, these types of technologies such as the exoscope, and even incorporating the exoscope in our education of residents, is going to be easier for transition to use heads-up display and not look in the cavity, but look at a monitor straight ahead. And I think that lowers the learning curve. But there are things that we still need to understand. These things are quite sophisticated. The technology can be quite overwhelming. There's voice control. We could switch between 2D, 3D. We could track our suction. Positioning the device is important. Positioning yourself is important. Understanding, where the monitor should be, understanding whether you should be sitting or standing for a posterior fossa tumor, and then understanding kind of the limits of the robotic arm and movement is something that we've learned. And this is a paper we published, one of the early papers probably for use of the exoscope in lateral skull-based surgery. But this is kind of the learning curve I envision for neurosurgeons. And I do believe there's a more shallow curve for those who have endoscopy experience, and probably a more steep curve for those who are just traditional microsurgeons who haven't had much experience with endoscopy. But the 3D option in the exoscope is certainly flattening this curve. So, but the concept is different, right? We're looking at a monitor heads-up display, and we're merging our technologies. We're not looking at the cavity. And then, of course, you see here, the entire team is looking at the monitor. So everybody knows exactly what you're doing, and they're engaged. So this is, a case we did not so far back here. And it just, I think it engages the entire team. And it makes surgery fun. This is one of my colleagues, Dr. Hongyang Zhou. We did one of the first cases with the 3D version of this, and you can see here we're both engaged in the surgery together, talking to each other and operating together. We were able to kind of showcase the 3D new technology at the CNS meeting last year in San Francisco. This was a live surgery. I don't know if some of you were able to partake in that. This was a recurrent glioblastoma case. It was on October 21st. And, we kind of highlighted some of the strengths of the voice-controlled 3D system. This is a recurrent GBM. I had operated on this gentleman on the right-hand side, and he developed a contralateral recurrence. As you can see here, the DTI highlighted some of the tractography, the motor fibers, ventral to the tumor. And, you can just see here this beautiful view. So the exoscope's up by my shoulder. And look how nice this view is and magnified in this subcortical space where the tumor is, and kind of dissecting circumferentially around the tumor for this recurrent glioblastoma. Recurrent GBMs can be quite difficult tumors after chemotherapy and radiation therapy. This is just the post-op MRI scan and the post-op diffusion tractography imaging showing the cortical spinal tract still intact. The guy is actually still hanging in there, close to a year now after his second surgery, and he's had some new chemotherapies. So, recurrent GBM, the progression, the overall survival is usually 6 months after recurrence. So we're hopeful with him, but it is glioblastoma. It is a terminal disease. But I think, this is just an example where, we feel that the surgery with the exoscope may have helped us. So this is some of our early data. We just published this in the Journal of Neuro-Oncology, hot off the press, and really kind of highlights our outcomes in 26 patients who underwent 28 resections purely with the exoscope. And these were all GBM patients in predominantly eloquent tumors that were quite large in size. 25 were new GBM tumors, 3 were recurrent tumors. Almost half of our cases underwent cortical motor mapping. We did collect extent of resection data with our patients to really kind of look at how well we did with the exoscope. And granted, this was not a study where we had a cohort where we did standard microsurgery. We published other papers with that and with fluorescence-guided surgery. No fluorescence-guided surgery was performed in this subset of patients. So this really was purely exoscopic resection of GBM patients that were predominantly new. And we looked at our complications really at a month, and then our outcomes, specifically progression-free survival at 6 months. All these patients had whole brain tractography overlaid with their neuronavigation. We did perform, as we mentioned, intraoperative cortical subcortical mapping in 15 cases using a high-frequency monopolar stimulation mobilization. And then the heads-up display was used with these technologies and the exoscope during surgery. And as I mentioned, there was no 5-ALA given in this series of patients. As you can see here, 28 tumors were resected. We actually had 2 patients where we did a re-resection for recurrent in those patients, and 7 of those patients had positive mapping out of the 15. The 61% were subcortical in location. Most of them were unmethylated, and almost all of them were wild-type IDH1, with some with mutation. Here's another case example. You can see here a thalamic GBM, quite large in size, and we were able to use the exoscope purely for the resection of this lesion. And you can see the tumor sizes were quite robust. I think that the median CC was 24 cc's, and we looked at our series, and our median extent of resection was close to 95%. We categorized a large extent of resection greater than 78% based on some of the literature that's been published out of UCSF. You can see here our operative time was 221 minutes, and our blood loss was about 220 mLs as a mean. Our complications were quite standard with the existing literature. I think our 30-day complications were pretty much, I don't think there's anything really to highlight here. The mortality at 6 months was 0. We didn't have anyone die within 6 months. And our progression-free survival was about 86% at 6 months. The majority of patients were discharged home. We did have 1 go to a skilled nursing facility, and then 10 go to rehab. And then all the patients underwent the STOOP regimen, except those that had a recurrent tumor. We did have some immunotherapy patients undergo treatments, and then Novocure treatment. So, and the literature kind of supported our complications with this current series that we report to you. We didn't have any postoperative hematomas, and that's always quite nice in GBM resections, especially larger tumors that are quite vascular. And I do believe that the exoscope, because of its magnification and panoramic view, does permit, in our hands at least, better hemostasis for these tumors. So, I think in summary here, I know I'm running out of time here, but, the exoscope, we believe, resulted in excellent short-term results with a median extent of resection of 95%. And I think, our data in our study is in line with the majority of studies reporting outcomes following a traditional microsurgical resection. This was not a direct head-to-head comparison. That's something that we'll consider doing in the future, but we did feel that we had a favorable complication profile in this series of patients. So, of course, there's limitations. It's a retrospective study, so there can be selection bias. I think, not all centers have this technology, so, it's hard to generalize our conclusions here. And, of course, We didn't have a control group we talked about. And, I think further studies are really needed to explore this in the future. So, I think in conclusion, we do strongly believe that intraoperative visualization technologies are essential. And that's something that we've been really pushing for here at Mount Sinai in New York City. Of course, we got to keep our patients' best interests in mind when evaluating these technologies. So we believe that in our series, we had a large volume of tumor removal and substantial rates of PFS survival at 6 months. And our complication profiles were comparable to traditional microscope GBM series. But the combination of intraoperative adjuncts is really going to allow us to permit safer and more complete resections, as we hear more about that today and tomorrow. Again, thank you, and I appreciate the honor of speaking among the distinguished panel of talks today.
Thank you, Doctor. So our next speaker for today is Dr. Jason Sheehan. Dr. Jason is a professor of neurological surgery at University of Virginia and neuroscience with 250 peer-reviewed papers. Dr. Sheehan is also the editor-in-chief of the Journal of Neuro-Oncology and is also editor for the SNAS. Today, he'll be speaking on big data studies on SRS for pituitary adenomas. Over to you, Doctor.
So I want to thank the Pakistan Society for Neuro-Oncology for organizing such an outstanding meeting. As I looked at the program, I was honored to be a part of it and impressed with the list of speakers. In many ways, I felt that the conference was one that reflected a conference that had been going on for years and years and years. In fact, the first meeting to pull off a conference of this caliber was incredibly impressive. So I'm going to speak a little bit today about stereotactic radiosurgery for pituitary adenomas, some contemporary multi-center studies, and the idea of using big data approaches in neurosurgery to try to get answers and to advance the field in a more meaningful way. So I just want to touch upon the fact that over the last 50 or so years, there's been an incredible amount of effort to advance the field of stereotactic radiosurgery in proton therapy, as shown on the upper part, LINAC-based radiosurgery, and gamma knife surgery. And that it's really been through a multidisciplinary approach through radiation oncology and neurosurgical collaboration, along with medical physics, that we've gotten to where we are. But in many instances where the foundation was laid, it was laid upon single center, small numbered cohort studies. In fact, my colleague, and I sit in the area where his office was, Dr. Steiner, in 1970, published the first successful case of gamma knife radiosurgery obliteration of an arteriovenous malformation. That was a case report of a single patient who had 19 months of follow-up. Such information, although incredibly meaningful and paradigm shifting at that time, would fail to really be able to be published in our top tier journals now. And our ability to shape the field is really going to be around multi-center studies. So why do we choose to look at multi-center data for pituitary adenomas? Although from a neurosurgical perspective, it may seem like pituitary adenomas are plentiful. In fact, they're relatively rare tumors. The prevalence is only about 75 per 100,000 patients. Long-term follow-up is essential for these relatively benign, and I put that in quotes, tumors, and that most of the literature to date, particularly in the neurosurgical literature and the radiation oncology literature, there are some exceptions in the medical oncology, in the medical and endocrine literature, but most of our neurosurgical series and radiation oncology series are single center studies with low statistical power, few patients reaching long-term follow-up, selection biases that reflect in individual sites, inherent bias towards one approach or another, and maybe have limited generalizability to other centers. So we started looking at, through the International Radiosurgery Research Foundation, non-functioning pituitary adenomas. And we published this study in the Journal of Neurosurgery. It was 512 patients, the largest series to date, of non-functioning pituitary adenoma patients who were treated with radiosurgery. This was in 9 centers participating through the consortium. The distribution of male and female was pretty evenly split, with a slight predominance towards the male patient population. The number of these patients, most of them had prior resections, 94%. So that, in fact, radiosurgery was used seldom for upfront treatment for non-functioning adenomas. Prior radiation therapy was delivered in about 7% of patients. The patients at baseline had these degrees of hypopituitarism affecting various axes such as cortisol, thyroid, gonadotropin, growth hormone, and diabetes insipidus. What we saw with patients over the time span of 5 and 8 and 10-year actuarial progression-free survivals was 95% at 5 years and 85% at 10 years in terms of progression-free tumor survival for single fraction radiosurgery to a non-functioning pituitary adenoma. We were able to identify some prognostic factors from this large multi-center cohort study. Patients with tumors less than 5 cc's pretended a better chance of progression-free survival after single session radiosurgery. Patients that had a margin dose of at least 16 gray or higher in a single fraction radiosurgery delivery to their non-functioning pituitary adenoma had a greater chance of progression-free survival as well. And these were statistically significant differences. We also felt it important to look at the clinical outcomes of these patients, specifically cranial nerve deficits following single session radiosurgery. And in this paper, we noted a risk of about 9.3% for new or worsening cranial nerve deficits. Generally larger tumors, tumor progression, prior radiation therapy, or increasing age portended an increased risk of a new or worsening cranial nerve deficit at last follow-up. Interestingly, we talk a lot about cranial nerve 2 deficit in radiosurgery. The radiosensitive nature of the optic apparatus is well known. However, that risk was actually much lower than might have been extrapolated from historical data. The risks of other nerves, cranial nerve 3, 4, 5, 6, and 7, was typically only about 1%. Endocrine response in terms of hypopituitarism and non-functioning adenomas treated with radiosurgery, the risk of that was about 21% at last fall. There was a differential response, and we published similar reports in the Red Journal in Radiation Oncology about differential radiosensitivity of pituitary hormonal axes. In fact, thyroid hormone was the most common deficit after radiosurgery, followed by cortisol and growth hormone. These hormonal deficits don't all need to be replaced, and in fact, growth hormone is oftentimes not replaced in certain adult patients, but thyroid hormone and cortisol certainly would. Increasing risk for hypopituitarism after radiosurgery were increasing margin dose, prior radiotherapy, and a worsening cranial nerve function. We then took this same research consortium and built upon this and accrued some additional sites and looked at the impacts of early versus late radiosurgery for patients with non-functioning adenomas after a prior transfemoral surgery. And in fact, what we did was to do a matched cohort analysis. We needed enough patients, we needed enough statistical power to look for differences in outcomes for patients who were treated with early radiosurgery to find that within 6 months of prior resection versus those who were treated in a delayed fashion more than 6 months after the prior resection. And in fact, as we published in this journal report, the multi-center one shown here in the lower right of this slide, there was a statistically powerful difference in terms of the tumor failure when one looked at late treatments versus early treatments, thereby suggesting that earlier treatment in patients who have a longer life expectancy of harboring this non-functioning pituitary adenoma and having it grow may actually be advantageous. We took it one step further and then looked at the risk not only of progression-free survival, but of endocrine response, the risk of hypopituitarism. And in fact, early radiosurgery portended a better chance of avoiding hypopituitarism, presumably because the tumors were slightly smaller and the distance between the remaining target, that is the remaining residual non-functioning adenoma, and the normal structures was greater after resection than waiting and having that potentially grow a little bit. But let's pivot and talk a little bit about multi-center studies for Cushing's disease with radiosurgery. A classic example of mini-G shown and described by Harvey Cushing in his seminal work, The Pituitary Body and Its Disorders. We published in the Journal of Clinical Endocrinology and Metabolism, the leading endocrinology journal, that we were able to successfully treat patients with gamma knife radiosurgery and Linac-based radiosurgery for Cushing's disease. Initial remissions shown here in this Kaplan-Meier plot show a greater than 75% endocrine remission rate after all anti-secretory medications and suppressive medications were removed. And the response was durable. So if we look out to 5 years and 10 years with this multi-center cohort study, we were able to project results much, much further than any single individual center could do. We looked at prognostic factors for initial remission, durable remission, and recurrence after remission. And in fact, lower dose portended a greater risk of endocrine recurrence after remission. This was one of the more modifiable factors, giving a higher optimal dose, somewhere on the order of 20 to 25 gray in a single fraction for patients with Cushing's disease, portended a better chance of a durable, of an initial remission and a durable response. We also looked at repeat radiosurgery after recurrent Cushing's disease, that is, patients who had an initial remission, then a recurrence. We, in this study, pulling together 20 patients from across multiple centers, because very few centers had many recurrent patients, that we found that a slight reduction in dose was typically given, rather than 25 gray, giving 20 gray in a single fraction. But that remission rates weren't a whole lot different, 60% as compared to 75% in the upfront patients who were treated with radiosurgery. We published this multi-center study in the Journal of Neuro-Oncology about 1.5 years ago. Now I'd like to pivot and talk a little bit about acromegaly and the power of multi-center studies in this context. Certainly, again, another seminal case of a patient with acromegaly that developed gigantism, described by Harvey Cushing, a patient of mine, Sultan Kulsin, who was treated with radiosurgery for his acromegaly and described in a discovery documentary as well as in the Guinness Book. We pulled together patients from across multiple sites, again, using a research consortium of radiosurgery centers that spanned not just the US, but was an international cohort study. We had 371 patients, again, the largest study to date of acromegaly patients treated with radiosurgery. And what we found with a mean follow-up of 79 months was that we were able to achieve a nearly comparable rate of endocrine remission as we saw with Cushing's disease, slightly less, but almost comparable. And that this endocrine remission was a durable one. Out well past 5 years, we had 63 patients, and well past 10 years, we had good endocrine responses in 15 patients in longitudinal long-term follow-up. Again, looking at prognostic factors that projected initial remission, durable remission, and recurrence after initial remission. Some of the things that projected initial remission were a lower random growth hormone prior to radiosurgery, prior resection, so again, reducing the size of the tumor, a cessation of anti-secretory medications. That's actually been a little bit controversial, but this is perhaps the highest level of evidence we have with the largest cohort study suggesting that a brief cessation of anti-secretory medications around the time of radiosurgery portends a greater chance of endocrine remission as well as a durable remission. And then certainly a higher margin dose was a predictor of a more durable as well as initial remission. So hypopituitarism is the single biggest risk after radiosurgery, but being able to quantify that for patients is a challenge. Single center studies lack the sufficient statistical power and have inherent selection biases. So again, we pulled together sites across a wide group of leading academic and busy private radiosurgery centers. In this cohort study that we did, 236 patients, we were looking at specific point doses along the hypothalamus, the pituitary stalk, and the normal pituitary gland. And we had a median follow-up of 43 months. The risk of hypopituitarism was 18.6%. The time to hypopituitarism after initial radiosurgery was about 21 months. We found that there was a powerful predictor of the dose to the stalk versus dose to the normal gland. A higher ratio of that, as is shown here in this plot with the black line here, showed a cumulative increased risk of hypopituitarism. So if we can keep the dose to the stalk relative to the dose to the normal gland to less than 0.8, we're far less likely to induce hypopituitarism. So again, defining the anatomy, not just looking at the target volume and the dose you're giving to that, but looking at the critical structures around it can make a meaningful difference in terms of endocrine response. We now have a larger study that has been submitted with over 1,000 patients through the Radiosurgery Research Foundation. These patients were treated for functioning as well as non-functioning adenomas with single or multi-session radiosurgery. Hypopituitarism the first year was 7.8%, and at 10 years out, it was 31.3%. So finally, I'd like to talk a little bit about the NeuroPoint Alliance. The NeuroPoint Alliance is a research group that's been put together through the help of the AANS. Its a specific mission is to build prospective quality registries in neurosurgery and in affiliated fields. We have a radiosurgical registry in the US that is represented by these sites that are shown here. There's a mix of busy academic sites as well as private sites that are pulling together their data. This radiosurgery registry builds upon a platform that uploads clinical information, patient outcomes over time, and the imaging data obtained at the time of radiosurgery, as well as subsequent follow-ups. The imaging data and the clinical assessments are uploaded into a cloud-based registry. We're able to generate reports and be able to export them. We're working closely with radiomics colleagues in Hamburg, Germany, to look at the information we have in the registry for the imaging and to be able to develop predictive models of success or failure after radiosurgery. We're also working closely with big data groups such as the Mayo Clinic, who are helping to evaluate the large multi-center data that we have. We have now more than 7,000 patients in our registry and individual events that have follow-up on these patients that represent a number of different intracranial pathologies. Pituitary adenomas, which I've talked about, are represented here in the cellular tumor cohort, but perhaps our biggest indication for radiosurgery in the US is metastatic disease, and that's where some of our data is already quite mature. We're accruing patients with meningiomas, glial tumors, AVMs, and nerve sheath tumors such as vestibular schwannomas that are being accrued prospectively as well. So in conclusion, I'd like to say that randomized controlled trials for pituitary surgery or radiosurgery are not likely or particularly feasible. These tumors are relatively rare, and it is difficult to organize a prospective randomized controlled surgical or radiosurgical trial. Our best hope of advancing the literature is through multi-center, high-quality cooperative studies and registry-based platforms that allow us to advance the field more meaningfully than we've ever been able to do for some of these rare tumor histologies. So with that, I'd like to thank the organizing group. I'm honored to be part of this and happy to participate in some question and answer later on in this session. Thank you.
Thank you, Doctor. So now we'll be moving towards our final speaker for today. Dr. Mitchell Berger is chair of the Department of Neurological Surgery and director of the Brain Tumor Research Center at the University of California, San Francisco. Dr. Berger is also a leader of translational research and is the principal investigator of the UCSF Brain Tumor Research Center's specialized program of research excellence in neuro-oncology, funded by the National Cancer Institute. Today, he'll be speaking on awake glioma surgery, lessons learned in 35+ years. Over to you, Doctor.
Thank you, Namra. Can you hear me okay?
Yes, we can hear you. Thank you.
Yeah, Arthur, how are you?
I'm fine, thank you. Thank you for joining us.
No, I'm thrilled to do so. And let me just get my slides. So this is a very, very wonderful meeting, and it's a wonderful agenda for the Pakistani Society to have a neuro-oncology meeting. And I'm very, very delighted to be part of it and to have gotten to know many colleagues over the years from your part of the world. And we look forward to having you come visit us in San Francisco as time goes on, when the COVID crisis settles down, but we're delighted to participate. So today I'm going to talk not about translational research, but about mapping, but mostly to try to tell you a little story, maybe, and a story about how things evolved in my world in terms of doing the mapping, why I got into it, and what some of the benefits are. I think if you're a glioma surgeon actively, you have to be able to do this type of surgery. And it has many applications, as you'll see, for dealing with tumors. If I go back into my career, which now spans nearly 38 years, there were two things that drove me down this pathway. And one of them was the idea. As a resident, I learned that in order to make an impact on these tumors, we needed to be aggressive surgically. But back at that point in time, things fluctuated between doing biopsies and more aggressive resection. So the story was not written yet with regard to extent of resection and outcome. And I'm not going to go over all of those studies today. I'm just going to talk about the technology or the technique of awake mapping. When I went to the University of Washington for my first job, I was able to observe George Ogerman, who is a functional neurosurgeon, doing surface-based epilepsy surgery. And of course, it struck me that by understanding the function, we could be more aggressive with extent of resection. So those were the two things that drove me. But the real situation at that time, when I was finishing my training in 1985, was that there was not much in the way of understanding of how to do these functional cases with mapping as it related to neuro-oncology. So I had to kind of make it up as I went along, and I drew on an evolving literature that was coming out of Boston based on autopsy and stroke studies showing that the brain was seen as a group of local functional components that were connected underneath the surface, which explained a number of the types of neurological syndromes that we saw. But what we didn't realize at the time was that this was a very interesting concept as it related to plasticity. And we'll come back to plasticity later, because at this point in time, we really did not know if it existed. As time went on, in the late 50s and early 60s, we had Penfield in Montreal working on stimulation mapping, which had started many, many years ago in Germany with the basic components of excitation of the brain during surgery. And then this evolved into what we know as brain mapping. So this is the basis for which I had to use during my journey through this process. And it soon became clear to me, and just to skip ahead in terms of the outcome that we've all benefited from with more aggressive resections, is that we now understand and appreciate the fact that the standard of care, whether it's in Pakistan or whether it's in the US, involves an aggressive surgical approach to try and reduce the size of the residual disease to the greatest degree possible. Now, recently, we just wrote an article and published it in JAMA Oncology showing that, at least for glioblastoma, we have to go beyond the contrast enhancement, and we have to go into the flare abnormality. And this is a paradigm shift in our understanding of extent of resection. And we're repeating the same study with low-grade gliomas as well. The other thing that is important here is the fact that safety is a critical component of what we do. And realizing that safety is so important, certainly it has been so for me, combining the two techniques to be safe while I'm doing an aggressive resection, I think was a very optimal way to proceed in my career. So as time went on and I saw all of these other beautiful technologies emerge throughout the world with navigation, with intraoperative imaging, et cetera, it became very clear to me that function was still the most important part of the operative procedure, and that we really needed to think of neurosurgery as doing surgery similar to flying a plane at night, where all we could use is radar. We couldn't see where we're going. And so basically, it's not so much about the anatomy, it's more about the function. So how do we get to that point of understanding functional localization in the brain? Well, this really was, I think, one, if I had to go back, and I think we should all do an exercise where we go back and look at the most important studies we've ever written in our career, this is probably in my top 5 for sure, because this was the first way in which we were able to assess language function. And what we found in this study, which was basically half epilepsy, half neoplastic lesions, for the first time, is that with regard to language, there was a huge amount of variability in human language. And in fact, to this day, and as you'll see in this series of over 1,500 awake cases, I've never found 2 patients who've had the same exact language map. So things are very, very different. Okay, so variability is critical, and I'm going to demonstrate this as we go further. But in this important study that we published, which at the time was the largest study ever published on human language, what it showed us, in addition to the fact that no two people had the same map, it also pointed out to me at the time that I had to have a positive map before I could get to believe in removing tissue. So basically, when I started my career, I was doing these very large exposures, making sure that my mapping was working, that I had a positive map, and that having negative stimulation mapping did not give me the information I needed. So this just shows you, starting out, I'm very different than now as I've moved through my career. So this confirms the variability issue, and it shows how variability is incredibly different in every individual. So if you look at patients with speech arrest versus naming, and if I look at all the cases I've ever mapped, and I saved all those points throughout my career with navigation, and then I developed these probability maps, we found very, very clearly that even though there's a variable distribution of speech arrest or naming as seen in green, there is a very significant probability of finding these language functions in given areas like where you would expect, but you don't always find speech arrest in the classic area of the frontal operculum. Sometimes you can find it in the superior temporal gyrus where you never would expect it. So there is a great deal of variability. And for that reason, we need to map everyone, whether it's in English or whether it's in a foreign language, etc. In terms of the following this pathway with the variability, this is a study now that looked at the functional outcome in language mapping. And this then became, in 2008, the largest study ever published on human language. And now you can see the shift in my whole concept of function, in the sense that now I was showing that I could do very focused exposures and get a negative language map, and that I could base my resection on that. So this is now a very big shift, and you'll see this as we maybe look at a few cases as we go along. Now, to prove that that was acceptable, carefully the deficits when we published this article in the New England Journal, and we showed that relying on negative data, we could get a very high degree of predictability of who was going to have a deficit and who wasn't. So bottom line is, if you use a very focused exposure and you do a smaller resection and mapping, even if you have a temporary deficit, the likelihood of a permanent deficit is still very acceptable at around 2 to 3%. And if you're thinking about what happens in those patients who are left-handed, who are right hemisphere dominant for language, turns out, based on the study that we wrote a few years ago, that language sites on the right side are essentially the same in terms of distribution and variability. So there is no difference in the way the brain programs language organization. Now, as I mentioned, there is a period of time during this resection afterwards where patients don't look very, very good. And so this is pretty typical. In the cases I did this week, patients are just starting to show some improvement. But so if you look at all these different functions, pre-surgery where you're at baseline, and then you look 2 to 3 days post-operatively, you can see that fluency and things like repetition and comprehension, all of these aspects of language deteriorate. So you have to be prepared to see this in your patients as you move forward in the post-operative period. So bottom line is, when we looked at this, this was a study I did with Hugh Defoe, Philip DeWitt Hammer, representing a complete analysis of every paper ever published with or without stimulation mapping. It shows that if you want to reduce the morbidity in glioma surgery, you can do so by 50% if you use stimulation mapping. So this is now the standard of care. So that brings me to the first part of this talk, which shows over this period of time an evolution. When we started, we didn't know how much of exposure, we didn't know how much mapping to do. We had no idea how to map subcortical systems. We were just mapping the cortex, big sections of it. And now, 30 plus years later, we're doing very focused exposures. We're relying on negative mapping to do our resections. We are interrogating the subcortical system so that we understand the connectivity pathways, and we have, as you'll see, a greater knowledge on plasticity. So this just shows you my experience, which as of the COVID era, started to move into COVID. This put me at nearly 1,600 awake tumor resections over the course of my career, both at the University of Washington and at UCSF. And I'm just going to share some of this with you. I'm not going to go into the significant technical aspects of this because we don't have time for that. But essentially, it requires a number of critical aspects. One, you have to have a very dedicated team of anesthesia folks who understand that it's a team effort. They don't tell you what anesthesia to use. You work with them to decide whether to do this under local or a laryngeal mask, or with propofol or dexamethasone or remifentanil. It's a complicated strategy, and you have to work with a team. As I said, we do very focused exposures. We map any pathway we're interested in. So if we want to work in the right parietal lobe and a patient has a hobby of playing a guitar, we're going to interrogate those pathways as they're playing the guitar during the surgery. So we can map any function we possibly want to map. And we're going to do this both cortically and subcortically. The technique that I use, essentially, again, without going into this great detail, is the asleep, awake, asleep technique. So we're going to put the patient to sleep, and we're going to do the exposure. We're going to wake them up for all aspects of the mapping, including the subcortical mapping, and then we're going to put them back to sleep after the resection for the closure. Sometimes we put them to sleep, we wake them up, we go back and forth into this process. And it just depends on what we're interested in doing. This just shows you how we have to be flexible during the course of the surgery. We have, in a situation like this, I've changed the anesthetic regimen 40% of the time before I even make the skin incision. The other day I was doing a case with a patient who clearly was not tolerating the local anesthetic. So I said to the anesthesiologist, use the LMA. We did the LMA, and then we exposed it. We woke the patient up. And there is a sense of confusion early on, but again, as long as the patient's secure in the head holder, there's no problem. So you just have to be flexible. Complication rates, not really terribly different now in my career versus when I started, about 2 to 3%. And the likelihood of seeing seizures is very low and acceptable as well. Now, when we see a deficit, the first question that comes into mind is whether or not there's an ischemic injury or there's a tract injury. So to do that, we are now doing repetitive diffusion imaging postoperatively so that we can look for either ischemic-based injury or we can look at disruption of a tract. and this is a study we published recently, where we were able to look at the degree of the deficit and the recoverability of that deficit based on the portion of the tract that was intact or not intact. And you can see beautifully here a patient where part of the tract of the IFOF was affected, yet the patient did not have a permanent deficit because the entire tract was not transected. So this gives me great insight now into being able to predict this. And what I think it's going to do as time goes on is we will write a definitive paper showing the percentage of the tract resected and the outcome of that patient. Sometimes we cannot, even under best of circumstances, get complete mapping identification of all aspects of the tract. And so obviously we're going to see pieces of the tract transected, but that doesn't necessarily translate to a deficit. This is an article my good friend Jason Sheehan, who you just heard, just a brilliant radiosurgeon, neurosurgeon, the Journal of Neuro-Oncology, asked us to put together a review article on glioma surgery, and I appreciate Jason asking me to do this. And this will appear soon, so I ask you to refer to this article on the technical aspects of awake mapping. But it just goes to show you, as we indicated in this table, that there are different functions you can map depending on where you are in the subcortical or cortical pathway at any given time. So this is what has made the mapping procedure very, very interesting, is you can test function depending where you are. And if you look at this, I think the other aspect of this manuscript that's interesting is the incredible and almost worrisome variability of deficits seen throughout the literature in people who use this technique, showing that we still do not have a standard of acceptance. Now, there are people who have extremely high volumes in doing this. I see my good friend and colleague Jinsong Wu, who's the master of awake surgery in Asia, in China, and Hugh Defoe and myself and others who I think do things very similarly. So we have very similar deficit rates, but the reality is, without standardization, we're going to see all different kinds of percentages of resection. So we need to work on, over the next 5 to 10 years, standardization in this technique. Just like we have standardization in my operating room. Every time I go into my operating room, this is what it looks like in terms of the setup where I'm located, the patient, the monitoring team, and the other aspects of technology in the room. And the tests that we use are fairly traditional tests in terms of object naming and reading. And I think that now we have very good understanding of how to identify the different components of the subcortical language pathways. We published an article recently in Brain and Language showing that there are 2 tests that we typically use to identify the ventral stream, meaning the inferior frontal occipital fasciculus, where stimulation will induce semantic paraphasias using a picture word interference test that we show patients, and sentence generation, where during stimulation they have to tell me very quickly what the test or what the picture is showing. And if I am in the pathway of the arcuate fasciculus or the SLF, I can see stimulation-induced phonological paraphasia. So object naming, reading, basic counting, motor function, sensory systems, tests for apraxia like line bisection, subcortical systems, ventral versus dorsal stream. You can begin to pick all of these pathways apart during the course of your mapping. Now, I think I've got about 10 minutes left, and I'll just go through some other technical aspects of the subcortical language mapping. You can see this is my way of doing it, where I will stimulate with my left hand and I'll have my cavitron on the right hand with the patient awake, doing the subcortical testing, looking for these subcortical pathways as I've shown you how to identify them. I wanted to say one thing about plasticity, and of course I've learned from my good friend and colleague Hugh Defoe about the concept of plasticity, and of course he understands this better than any of us. But in my way of thinking about it, it's come down to the idea that plasticity is a function mostly in the brain at the level of the cortex as opposed to the subcortical system. So we see patterns of shifting function to the contralateral motor cortex. And this is the basis for our ability to now start using transcranial magnetic stimulation of the contralateral brain to promote plasticity. There's a beautiful study that's going to be published by Sandro Krieg and our colleagues from Germany, showing that they can reduce the motor deficits postoperatively if they early on stimulate the contralesional motor cortex, because they're promoting plasticity. This is a landmark study that's going to come out. We're now beginning to do this study in San Francisco using transcranial magnetic stimulation to see if we can also improve plasticity. The interesting thing is, when we look at the white matter system, we don't see the level of plasticity. So if you cut the subcortical system, subserving the ventral or the dorsal stream, you are not going to see plasticity. And so this is now a major point of our understanding of plasticity: is cortical localization promotes plasticity. Subcortical systems, once you get beyond the U fibers, we don't see the plasticity, so you have to be careful. Here's a perfectly good example. Case I operated on where I found these functions, did the resection. 30 months later, the tumor comes back. I reoperate, I remap. I don't find the same functions. We see movement of function away in 40% of all chronic lesions like low-grade gliomas. Critical, because if you do an operation and you see function in the cortex, leave it alone. Come back when the tumor progresses, and you have a 40% chance of reducing the risk of finding the same function. So the indications for an awake craniotomy, you name it, any of these types of lesions, right side, left hand, right hand dominant, it doesn't matter if you want to interrogate the motor, the language of the motor system. I'm not going to talk about a sleep motor mapping. That we feel very comfortable doing in most circumstances under general anesthesia, using a technique we reported recently in the Journal of Neurosurgery we call triple motor mapping. I'm just going to talk about awake surgery here and where we use it. So in a situation like this, where we want to resect a large frontal tumor and we want to come up against the dominant motor system, or where we might find speech arrest, if we're doing it in the temporal lobe, going all the way back to the vein of Lebet. If we're doing it in the parietal lobe, removing both supramarginal and angular gyrus, we can do so as long as we understand where the function is, and of course in the insula, and I'll show you an example of that as well. The beauty of this strategy for the insula, for example, is the subcortical transcortical approach to that. Okay, so I'm going to give you two examples before I stop of where this technique can help us become better glioma surgeons, certainly in trying to get to a lesion that's under the surface. So for example, in my way of thinking of removing gliomas, I've adopted an approach that I call a transcortical equatorial approach to the tumor. So in other words, if I want to remove a glioma in any location. The way I decide how to approach it is, what is the closest point from the cortex to the center of the tumor? And can I do this by mapping that cortex so that I can get to the center of the tumor and work my way through this? So instead of coming transsylvian here or subcortical, subtemporal, I prefer to do a transcortical approach as long as the function is silent. So for a deep-seated lesion like this, I'm going to map this area and I'm going to find where I can enter into a silent area. And then I'm going to map all the way down until I get to this tumor. And then I'm going to continue to map subcortically, looking for the function, whether it's motor function or language function. I'm going to keep the patient awake and move in through my trajectory to do this resection and to get to the bottom of this. So that's how I would do this. So let's look at an example of a case that I think is very complicated, has a high risk potential. It's a thalamic glioblastoma. How would you approach a lesion like this? I would approach it by going right through the inferior parietal lobule. This is the motor tract, just showing the motor system, but where is the language pathway? Well, I will map this region. Here's the end of the Sylvian fissure. I will use the inferior parietal lobe to go down through the cortex. I will map subcortically behind somatosensory cortex and above the superior temporal gyrus. So I will come through that supramarginal gyrus, that's silent, and I will enter in and then resect until I map these subcortical motor pathways. And on the postoperative scan, I do the resection I want to do. I stop where I get to the internal capsule. I've debulked this tumor. I've gotten the patient out of trouble. They can leave the hospital in 3 days without a language deficit. Very, very important. Here's another concept in reaching difficult access tumors like the insula. How do you get to an area like this? It looks easy to be able to do a resection in this area by splitting the fissure, but it's not as easy as you might think because of the nature of the tumor. It's very different if you want to clip an aneurysm in here, but when the tumor is exophytic over these arteries, it's a problem. And when it's compressing the lenticular striate vessel. So how would we approach a tumor like this? I would approach a tumor like this where I come through the transcortical approach through these windows of the M2 and M3 branches, primarily the M2 branches, and do the resection until I get to the lateral lenticular striate vessels, which I'll show you very nicely here. And if you've ever seen these lenticular striate vessels from a transcortical approach, and I would suspect many of you have never seen this, what the most important message I can give you is that these arteries are surrounded by arachnoid, which have CSF underneath them. So if you gently stroke the arachnoid and you see CSF leak out, you know those are lenticular striate vessels. Very important. So we published our data on the localization of insular tumors in different zones according to the Sylvian Fisher and Freeman and Monroe. We looked at this with regard to how we can get our instrumentation in, whether transsylvian or transcortical is better, and basically came up with the strategy I call the window technique, which I've published before, that allows me to go transcortical through windows between the M2 branches based on the fact that I've mapped the cortex and I find silent regions And then I can go all the way down until I find the lenticulostriate arteries, which I can see very nicely as I showed you in that picture as they come up here. And then we map the subcortical tract back near the internal capsule here. So if you take a lesion like this is a small tumor. You want to split the Sylvian fissure to get to this type of lesion. We will do this. And in those particular cases where the tumor is very, very small, you can see here, I don't have a problem with that concept of splitting the fissure to resect that tumor. And then you can see the type of exposure you get here and the opening you get. Now, in this case, I map the patient so that I can go transcortical if I need to go transcortical. But in this case, I didn't need to do that. Now, in this case, because as you see in this drawing, tumor often goes beyond the insula, we want a different approach here. And so in this situation, I have to take the frontal operculum off after I map it, and then to get back underneath in this region here, which is now zone 2, I have to go through here. So I have to split the fissure. So I do both transcortical through zone 1. Here's the M2 branch. And transsylvian to get under zone 2. If I need to go through zone 3 or zone 4, I do this transcortically. And so you can get a very nice exposure here to do exactly what you need to do. And this just shows you, based on an article we published, where we can now predict extent of resection based upon the zone of where this tumor is localized preoperatively. And this is my last slide, just showing that if you want to be able to get to this area, you can do so with these techniques. And this just shows you my experience, which now, up to this point, was about 351 insular gliomas. I'm now very close to 420 insular gliomas with the same ability to predict extent of resection and morbidity. Okay, so I will stop there. And if you're wondering why my face is now in a shadow on the west coast of the United States, it's of course morning. So the sun came up and now it's going behind a tree. So that's why I'm not in a shadow anymore. So as you go into nighttime, we are now into Friday morning. So Arthur, thank you very much. I appreciate the ability to address this very prestigious group of neuro-oncologists, neurosurgeons in Pakistan. And I can only hope and pray that I can visit Pakistan one day and see your beautiful country and experience your beautiful traditions and people. So thank you very much.
Thank you.
Thank you very much, Doctor. So we have now come to, an end to this session's panel discussion. Big thank you to all of our presenters for taking out their time to share their indispensable works in neuro-oncology. We will now move on to the question and answer session, for which we have 15 minutes. I would now like to hand over the session to the session chair, Dr. Tariq Khan, to take over from here.
Hi, thank you very much. Thank you to all the speakers, really excellent talks. And I'd like to tell you that nearly 600 people are in attendance today at this session. So it's a wonderful session. There were a number of questions. I would like to start with, first of all, with Hugo Dufault. Thank you very much for the excellent talk, and thank you very much for showing us the importance of plasticity in the brain. The question,
Tariq,
yes.
Dr. Dufault is not here at this point.
Oh, okay.
But
Right.
if
So,
that's a question, I'm sure Dr.
So the question to all the panel okay, is early maximal safe resection for low-grade gliomas after functional MRI better than radiation therapy for pediatric low-grade gliomas?
Well, for pediatric low-grade gliomas, I think it's very similar if they're cortical lesions. But please understand, of course, as I know you do, that many of those low-grade gliomas are really pilocytic BRAF mutation tumors. They're not the kind of tumors we would want to treat with radiation, so we're going to resect those. But for the classic low-grade astrocytic IDH mutated, non-BRAF mutated tumors, I think it's the same extent of resection maximization that we use in the pediatric as the adult realm. I don't think that varies whether it's in the US or in China or anywhere. I think we all feel that way.
Any other comments on this? So the next question was, what therapies have a rapid and dramatic effect on mass effect and contrast enhancement in glioblastomas? I'm not sure what.
You're asking what are the therapies that have advanced?
Yeah, so which have a rapid and dramatic effect on mass effect and contrast enhancement in GBMs. So are there any therapies which would increase the mass effect suddenly? Is the question to Professor Tufau, is not here. I'm not sure what it means really.
Mm-hmm. Yeah, I'm not sure what that means either. I think it's, maybe they're asking, how do you deal with a tumor that has significant mass effect?
Possibly.
I mean, Jinsong, do you want to answer, how do you deal with those big glioblastomas that have mass effect that you want to do awake? Do you have special technique for that?
Yes, in the early stage, I think the big enhancement, I mean, the high-grade glioma sometimes is not a good candidate for awake mapping, but at the late stage, for example, recently, I think this is not a contraindication for awake anesthesia. So our anesthesiologist, I think the female doctor, they can control the intracranial pressure very well. So I think we can still perform awake mapping. Thank you.
Thank you. So there was a question for Jack Rock, if he's around. What is the difference in recurrence rate of tumors after conventional craniotomy versus endoscopic surgery?
So Dr. Rock has also left, but I guess Kostas or Jason can easily answer that question. Kostas, you want to take a?
Sure. I guess maybe we could clarify what type of tumors. That may be helpful. Yeah. If they're referring to pituitary tumors.
Yes, because that was the talk from Jack Rock on pituitary tumors, craniopharyngiomas, and Rathke pouch cysts.
Yeah, well, I think the literature supports for some of the pituitary tumors that are suprasellar in location. The endoscopic approach, has shown some very good resection rates, and now the CSF leak rates, as Dr. Rock had shown, has come down considerably. For sellar pituitary tumors, I think the microscope is equally effective as the endoscope. So I think, I don't know if there's quite much of a difference between those modalities.
Thank you. So, Dr. Wu, thank you very much for good anatomy for the students of Insula and showing the importance of landmarks. The question is, what is the post-op care, especially for these sort of tumor surgeries?
Thank you for the question. I believe the most critical landmark for insular glioma resection is the lenticulostriate artery, just like Dr. Berger said. This is the deep margin of resection cavity. So in case we identify the lenticulostriate artery, we stop further resection.
Okay. And is there anything special in post-op management for these sort of surgery patients?
You mean the adjuvant treatment?
Yeah, post-operative.
Well, no,
For,
I think what they are, I think what the question probably might be is that when you have these small arteries, there's always a chance of them getting into spasm once you manipulated them. So what are your thoughts about keeping them well hydrated and you know, on the higher blood pressure side, those kind of things?
Immediate
Or,
post-op.
you know, some.
Immediate
so
post-op.
just like Dr. Berger taught me, we can use the papaverine pad to release the vasospasm, especially for the middle cerebral artery bronchus.
Tell us again.
What about the lenticular striate? What about the lenticular striate?
Papaverine pad will work on the lenticular striate artery because the wall, especially the muscle, is very thin. So I think it doesn't work, maybe, a papaverine pad. What's your opinion, mentor?
Yeah. Well, I think you're right. It doesn't work as well on these small branches, but I tell you, I think the most important message, as Dr. Wu said, is when you see those lenticular striates, you must stop. You cannot go deep to that because the tumor coats these vessels and they're impossible to find until you transect them. But the key thing is, early in my career, I made so many mistakes. I would think I was in a lenticular striate vessel and I wasn't. So I would stop short and it was just a tumor vessel. And I didn't understand how to see the lenticular striate vessels because I had never seen them from a transcortical approach. And it was only in one circumstance where the tumor came away readily from the fissure that I was able to appreciate the fact that there was a beautiful arachnoid plane around it. And I would see, as I disrupted it, CSF drops coming out, and a light went on in my head and said, that's how you distinguish lenticular striate from tumor vessel. And that has stood the test of time over the next, couple decades in my career. So very important observation.
Yeah. Thank you. That's very, very informative. And Dr. Wu, another interesting question. How do you map multilingual patients, idiographic versus phonetic, in your center? And do you feel that the language circuit to be different in your patients?
You mean different language?
Yes.
Yeah. Okay. So actually, we perform a meta-analysis of the retrospective data from Dr. Berger, Dr. Dufour, and our center, and some cases from Dr. Penfield, which published on the brain and language mechanism on his textbook almost 70 years before. So we think for speech arrest and anomia, we think the distribution, the probabilistic language positive sites, quite similar. Maybe for some complicated language function, for example, grammar, for example, grammar, or some word recognition, because the Chinese character is different from the alphabet. So maybe some difference between different language. But for speech arrest and anomia, we believe quite similar.
Well, thank you very much.
Dr. Berger had a very interesting case of a woman, I think, multiple language. You were mentioning it sometime when I was talking to you. I think this is several months ago.
You're talking to me?
A patient that you, yes, Dr. Berger.
Yeah.
You had a patient who had like multiple languages, and then something happened to her one language.
Yeah.
There was something I really remember.
Well, we will ask a patient always before surgery, do they speak more than one language? If the answer is yes, we ask them which is the most important language, because we will often sacrifice the other languages. When a second language is learned early in life, there are often different pathways that are seen. And so if we find a patient who has one language that they don't use very often, and we can take more of the tumor, then we'll take more of the tumor out and interrupt that language versus keeping the primary language intact. So this is a routine for us now to interrogate each language. So the question is to the patient, do you speak more than one language? Yes. When did you learn your second or third language? If they learned it before adolescence, then there's a higher chance that they're going to have different pathways for the same function. The subcortical system will be the same, but the cortical system will be different. So we will find out which language they are willing to sacrifice. We will take that language if it means doing a better resection. So that's what I was referring to.
Thank you. So there's an interesting phenomena in head injury patients that sometimes they will start speaking in the second or third language, which they would normally not speak in, and they would be very fluent in that. I wonder if so it's seen in many patients.
We published a article in the Journal of Neuro-Oncology. It actually got the cover of the Journal of Neuro-Oncology, discussing the acquired languages and the versus native tongue, and that there certainly is an age difference effect, as Dr. Berger indicated. We did we're doing a tumor talk webinars, and we did one in early August on this very subject. But I agree with Dr. Berger's comments completely, about the need to identify what language is the most important, and then also when that language, any secondary languages were acquired.
Mm-hmm.
Thank you.
Tarek, let me just say that in 3 minutes, I have to go to another meeting. So,
okay. So may I just move to a couple of questions for you. First of all is that what should be the size of cortical stimulation strength to avoid seizures and arrest? And if there is a seizure, how should we continue mapping?
well, I started in my career using stimulation between 2 and 6 milliamps, but now I kind of keep it at 3 milliamps or 4 milliamps to prevent seizure activity. And I use electrocorticography to tell me if I'm starting to see subclinical seizures so that I can back the current down. But if I have a seizure, we irrigate the cortex with iced Ringer's solution, 4 degree centigrade solution that ices the cortex and prevents propagation or depolarization of spread.
Okay. A question from the students and from the young trainees is, from you and Jason both, where to learn about brain mapping as beginners?
Well, I think what you need to do is you need to first read the literature. There's a lot of literature evolving. And as I said, the prestigious Journal of Neuro-Oncology asked us to write a review article on awake mapping. So, I mean, you read about this first, then you attend practical courses. So for example, we have a live surgery course every year. We do in London. Jinsong and I go with Hugh Defoe, Lorenzo Bello, and we break down the components of mapping, and we teach that. The students interact with us, and then you begin to do this with your own team. So I think it's a process.
Okay, thank you very much, Dr. Mitchell Berger. Thank you for your time.
I'll put in a plug that the NS CNS tumor section resident membership is no cost, and with that you'll have access to the Journal of Neuro-Oncology, which Dr. Berger alluded to, and be able to read a lot of the literature. Although it's not all in the Journal of Neuro-Oncology, certainly there are other access points. I know through AANS, CNS, and Society for Neuro-Oncology, and all the affiliate journals. So such bright young people coming behind us. I'm enthusiastic about the future of neurosurgery and mapping.
To Dr. Costas, thank you very much for your talk on exoscope and how it broadens the field of vision and the depth perception. And the question is that apart from the operator comfort, how do you compare it with other modalities being used?
Well, so I guess, are you inferring to other types of magnification devices, microscope?
Yes. Yes.
So, I think we have evolved from, the microscope's really our workhorse, but the endoscope is something that, we are using a lot in our practice, especially for skull-based procedures. I don't think we really use the endoscope for supratentorial stuff, except working channel in the interventricular space. I think that's probably where the endoscope is used the most. But for gliomas, I don't think we would use the endoscope much. So the exoscope's really kind of a hybrid, the way I see it, between the endoscope and the microscope that permits, really good visualization and clarity. And the image, again, as we mentioned, is a digital image. So that image can be processed in a number of ways, colors, different types of things that we think, could, delineate things better. So I think we're at the tip of the iceberg in regards to digital microscopy. And I encourage, everyone to learn more about it, because I do think we're on the road to digital microscopy in our future. I don't know when, but I think we're moving in that direction.
Yeah, thanks very much. Two questions for Jason. First of all, thank you for your wonderful talk. And thank you for pointing out the importance of neurosurgical registries. The first question was, what are the side effects of radiosurgery and how long do they intend to last?
Well, the benefits and risks of radiosurgery are usually realized over the months and years to come. And it depends really upon the underlying histology. But for pituitary adenomas, the biggest risk is hypopituitarism, and that can be a delayed risk, as I showed in the multi-center study that we're in the process of publishing with over 1,000 patients. The risk increased from about 8% in the first year or two to about 31% by year 10. But we know, for instance, with other indications, not just neuro-oncological ones, but with arteriovenous malformations, that the latent effects of radiosurgery in pediatric patient populations can be a decade or more. And we really need to be following these patients long term, especially when they're patients with what would be considered benign disease, although arguably no tumor is entirely a benign disease.
Thank you. And the other question is that does outcome and recurrence vary between opting for direct surgery when compared to initial treatment with dopamine agonists such as bromocriptine, or followed by endoscopic surgery? So
well, I deliberately did not talk about the use of radiosurgery for prolactinomas. There's a growing body of medical agents that are being used for acromegaly, for Cushing's disease, and certainly the classic examples of tremendous medical control for prolactinoma patients. And there is some increasing evidence of use for medical effectiveness for non-functioning adenomas as well. In general, though, one has to keep in mind that many of these medications have side effects as well, and that the cessation of the medications is problematic for patients. In other words, if they stop taking them, the hypersecretory state recurs, or the tumor grows, or both. So that if you can offer a patient an effective, if you will, cure, as I've showed in many instances for non-functioning adenomas with tumor control, or durable endocrine remissions for a decade or more with a single radiosurgery. I think it's in many instances not only a cost-effective but patient-satisfying approach. And certainly in patients who have recurrence after initial remission for radiosurgery, we might consider treating them again, depending upon the options. But obviously, we image the patients and make a determination if repeat resection or medical management would be used. In the instances with radiosurgery for remission, we always consider bridging patients during the latency period. Typical remission rates after radiosurgery for Cushing's disease are about, the latency period is about 1 year, and for acromegaly, it's about 2. So that you have to bridge these patients on medications to get their symptoms under control, much like with AVMs that take 1 to 3 years on average to obliterate after radiosurgery. There's a latency effect with radiosurgery for functioning adenomas. However, we are exploring radiosensitizing agents, and I think we can bring that latency effect down, and maybe with higher doses and more exquisite technology, imaging, targeting, we'll have a better opportunity to deliver the radiosurgery in a more effective fashion and decrease the latency periods even to shorter periods of time.
Thank you. So most of the other comments were congratulations and thank you all the speakers. So I'm finished with that. Over to Athar.
Oh, thank you. I mean, you were the chair of the session, so just wanted to appreciate everybody, honestly. We are all honored in Pakistan that you joined us. You guys are the best of the best in the world, and all coming together in one session was like the most star-studded session of the one annuals. But then, you know, don't go away. I'm gonna be calling upon on you next year again, and you know, we have to keep you engaged in this, and you have to stay with us in this annual Neuro-Oncology Symposium every year. So we look forward to it.
Hopefully in person next year.
Oh, yes, physically, yes.
Honored to be a part and look forward to future years, and I hope where we're not separated by the internet.
Yeah.
All right.
Thank you.
Thank you very much, everybody.
Thank you.
Bye-bye.
Thank you, Dr. Tariq.
Thank you so much.
Thank you. So.